Good morning. Welcome to the August 17th, 2017 Public Health Nursing Webinar. I hope it's as beautiful of a day in your local health department in your county as it is here. The sun's shining brightly in preparation for the eclipse on Monday, so we hope it stays that way so everybody can see it with their protective eyewear, wearing their protective eyewear. We'll go ahead and get started. My name is Joy Hoskins. I'm the Chief Nursing Officer for the Department for Public Health, and I also serve as the Division Director for the Division of Women's Health. And it's my pleasure today to introduce one of our new Division Directors, Dr. Jonathan Ballard, who is the Division Director for the Division of Epidemiology and Health Planning. And so Dr. Ballard has been here since April 1st, I believe is what he said. And so his division, Dr. Ballard and his team and his division, they touch so many areas of our clinical practice in local health departments each and every day. And so I wanted to make sure that you had the opportunity to meet Dr. Ballard, hear about what his division does, and so you can always kind of put that name with a face and feel comfortable and to reach out to Dr. Ballard and his team in the event that you need technical assistance or guidance on a particular issue. So I'll turn the camera over to Dr. Ballard. Dr. Ballard, thank you for being here with us today.
Thank you very much.
Okay.
It's an honor to be here with you today, Joy.
Yeah, thank you. The camera's all yours.
Okay, well,
You take your time.
again, thank you. It's a pleasure to be here with you today and to introduce myself to all the nurses and health department staff throughout the state. I serve as the state epidemiologist and the division director for epidemiology and health planning. And the role is unique and exciting for me. My background is I'm from Kentucky. I'm from Bardstown, Kentucky, originally in Nelson County, and did training at the University of Louisville in biology and then on in medical school. But in medical school, I became interested in many of the diseases and healthcare problems that focus and influence the health of more than one person in what we do in public health. And that's how I got interested in public health and in epidemiology and went on to do advanced degrees in epidemiology and public health. And so I have been a practicing family physician for the past 3 years at the University of Kentucky. And it has been a wonderful transition over the past 4 months here to the Kentucky Department for Public Health because of the background of my interest in family medicine being very broad, treating children from newborn until the age of death. And I've truly learned now in my role in the Kentucky Department for Public Health that public health influences the health at every point of the life cycle, and that the life cycle and family structures have a huge impact on our own individual health and the health of others. So in the role of state epidemiologist and the division director in epidemiology, that area encompasses the being a source or resource for the local health departments and district health departments in the areas of reportable diseases. We have a number of talented folks that are epidemiologists, the disease investigators that can help guide the disease outbreaks that you take care of so much at your local level. As well as in this division includes immunizations. And we're building an immunization registry that we hope will be successful and help you and help the local schools in providing coordinated communication in an easier way over time to accommodate the new regulations that may be taking place, which you will be hearing from Christy Royalty, a nurse in our immunizations program later today about. As well as in epidemiology includes the HIV branch. That's the Ryan White program that provides services for those individuals throughout the state with HIV, as well as prevention of HIV. So that is a large part of the division. Also, tuberculosis. Many of your work throughout the state is critical for us to maintain our threshold of combating tuberculosis. It's still around the world, and we have a different situation of how we tackle tuberculosis today than we did 50 years ago when it was such a huge prevalent issue. but the work today is still very critical because of multi-drug resistant tuberculosis. Also in epidemiology, we have areas of sexually transmitted disease and disease investigators to help prevent the spread of sexually transmitted diseases. And we know that's the work that you do so much of in your local health departments. And we thank you again for your work and want to be a resource for you as well. As well, in epidemiology, we're wanting to expand our efforts in harm reduction for the opioid epidemic and prevention of HIV and prevention of hepatitis C and B. Hepatitis is a growing area in Kentucky. We have the highest rates of acute hepatitis C in the country. So this is an area that we're going to be focusing on over the course of the next year and trying to better understand the situation of the disease and how we can prevent it through harm reduction programs. And we want to thank you again for all of your work, and especially the counties that have really tackled this issue and set up harm reduction programs. Very thankful for that work. The Division of Epidemiology serves as a liaison to the Kentucky Injury Research and Prevention Center housed at the University of Kentucky. That center does the research using the Office of Vital Statistics here in the division as well, which is the birth certificates, the death certificates, marriage, and divorce certificates that provide so much information as our baseline denominator information that we rely upon when we do any kind of disease investigation, so we know what our incidence and prevalence is. That information at KIPRIC is used for injury prevention in research and reports, as well as what includes now substance use disorder. And so we're tackling this issue. We very much thank you as well for all of your work in your local registrar, many of the local health departments, the nurses, the local registrars, or the public health director. Again, thank you so much for your work. All these efforts are critical for us in maintaining the prevention of disease and keeping the efforts that public health has done so tremendously over the past 100 years, the true unsung hero, marvel of what has happened for healthcare and prevention of disease. And we have certainly hot topic areas, but areas that we like to work on. One last area I want to tell you about a focus of mine, and I think it's because of modern technology, we really have to do that, is that as there's many electronic health systems across the state, they are becoming integrated with recording their data as far as disease cases electronically. This is something that has been started many years ago, and it will be the work of us for many years to come, whether it's through, and especially through the health departments as well as the electronic health records becomes more integrated and the problems with those electronic health records get resolved over time. And so electronic case reports will, I think, help with the local health department's work as well as our work, meaning that the reports over time hopefully will come from the electronic health records directly into the Kentucky Health Information Exchange or otherwise into the work that our epidemiologists in the Kentucky Department for Public Health do. And there's always plenty of work, we all know that, in public health. But this could help streamline our work. So that's going to be a real focus of us over the next several years. So we've hired a public health informatics officer that's going to be helping us with that effort to help determine what are our needs that we need to do and then act upon those needs to make electronic case reporting a timely and real thing on a larger level. Again, thank you. It was very much an honor to be here today to be able to speak with you. And really, again, the focus is to thank you for all your work. We serve as a resource. We have nurses, epidemiologists, and other types of staff members throughout the Division of Epidemiology. And please do not hesitate to call us if there's any questions or any work that you're doing. I want to plug the work that many of you do in your Epi Rapid Response Teams. Those are the trainings that we do twice a year in the Division of Epidemiology to help train your staff in basic epidemiology principles. Epidemiology is the study and the practice of prevention of disease and injuries. And your staff members have amazing talents and do disease outbreak investigations and control efforts on a daily basis. and we want to continue those trainings for the EPI rapid response teams and encourage their utilization for the local responses to whatever type of outbreak it is, whether it's a foodborne outbreak at daycare or whatever it would be, or those multi-state outbreaks or those outbreaks that cross over counties. The work that you do is critical for us to maintain prevention and deaths for a number of diseases. So again, thank you very much. Enjoy. It was a pleasure and honor to be here with you today, and thank you so much for putting on these webinars every other month.
Yeah.
Thank you,
Dr. Ballard.
Thank you.
As you can see, it's Dr. Ballard is a welcome and wonderful addition to our team. He's also a huge supporter of nurses, and as a nurse, you know, we all like to have doctors who like nurses. So, and so he's very supportive of nurses and all the work that you all do. And so thank you, Dr. Ballard, for taking time out of your extremely busy day to speak with us this morning. Next is my privilege to introduce Meg Savage. Meg is the legal counsel for the Kentucky Coalition Against Domestic Violence. And Meg, I've invited her to be with us today to talk about House Bill 309 and the implications of reporting, mandatory reporting for cases that are for patients who may present to your local health department. She's going to talk a little bit about the changes in those laws. So Meg, we're so happy to have you here today. Thank you for talking to the nurses. We appreciate it, providing this information and update for us. Yeah, there you go.
All right. So thank you so much, Joy. Yeah. As Joy said, I work for the Kentucky Coalition Against Domestic Violence, and we are your state domestic violence coalition. So we are an umbrella organization, over 15 member programs. There's one in each area development district. And as public health nurses, you're probably well aware of what the program is in your area. There's not one in each county, obviously. One of the handouts that I provided to Joy that I think you have access to is a map that shows both our domestic violence programs, and those provide both shelter services and also a lot of services for people who don't need to or want to come into shelter. And I think the map also shows where all of our state rape crisis centers are as well. So today I am going to talk to you about a new law. It's actually the revision of a law that's been in existence for quite a long while. It just passed in the 2017 session, so it is very new. It went into effect June 29th, and it makes a significant change in our mandatory reporting law, such that we really no longer have mandatory reporting of spouse abuse as we have had for quite a long while. So if we can pull up the PowerPoint, we'll go ahead and get started with that. All right, so as you can see, the bill that actually passed was House Bill 309. But as of now, seeing as we're past the June 29th implementation date, you will find this new law housed in KRS Chapter 209A. So it's a chapter of our statutes that's entirely devoted to this revised and reinstated law. In addition to speaking about the new law, we thought that it would be helpful as we go around the state and provide these trainings to various audiences, that it would be helpful just to give sort of a refresher course on the other mandatory reporting laws that we have that apply to really everybody across the state, not just nurses. So our new law applies to a certain group of listed professionals, and nurses are included in that. But then I'll also be talking about the existing laws that haven't changed concerning mandatory reporting and then talk a little bit about how to appropriately screen for domestic and dating violence and to make a good referral. So I'm going to skip over this first slide because that's something that we talk about when we're doing this as a webinar. But here are the objectives of this training. As I said, hopefully you'll walk away with a good understanding of what the requirements are under House Bill 309 or KRS 209A. We're going to look at the existing requirements that haven't changed and talk a little bit about screening and referrals. We always like to start off by giving a big shout out, first of all, to our bill sponsors. So obviously when you want a piece of legislation passed, you have to find a legislator who's willing to carry it for you. And the two legislators here, Senator Alvarado and Representative Prunty, were instrumental and worked really hard to get this bill passed. So we always really like to give them a big thank you whenever we have the opportunity. And then you can see what's listed here is all the organizations that actually signed on in support of this change in our law. So it is a relatively big change, but we do want people to know that it wasn't something that, you know, just a small group of domestic violence advocates thought was a good idea. You can see right off the bat that we have the Cabinet for Health and Family Services, we have the Justice Cabinet, we have various youth advocacy organizations, the Kentucky Association of Sexual Assault Programs, and you can see the Kentucky Coalition of Nurse Practitioners and Nurse Midwives, the Kentucky Medical Association. We reached out to the mental health care providers who really were in support of this law. So this was really a joint effort where we reached out to a lot of stakeholders and got their input and tried to create a bill that everybody was happy with. So we really are very positive about this change in the law. So again, under KRS Chapter 209A, that's where we have housed in the past the mandatory reporting of spouse abuse and neglect. We're also going to talk about KRS Chapter 620, which is where you'll find the mandatory reporting of child dependency, abuse, and neglect laws, and KRS Chapter 209, which requires the mandatory reporting of abuse, neglect, or exploitation of what I will call vulnerable adults. You're not going to see that word in the statute. That's just sort of an easy way to refer to those statutes. And then I'll talk very briefly about KRS 202A and KRS 645, which are the duty to warn, which apply to certain professionals and may apply to some nurses who are doing mental health care work. So this is the law that we had, and it changed as of June 29th, so it is brand new. The duty to report spouse abuse to the Cabinet for Health and Family Services has been replaced by a duty of certain listed professionals to provide educational material and information about domestic and dating violence to the patients or the clients or the individuals that they're having an interaction with. And the law has been expanded. So in the past, we only had a duty to report spouse abuse and neglect. So now this new duty to provide information is going to hopefully cover all victims of interpersonal domestic and dating violence. So the law used to require that any person that had a reasonable cause to suspect that an adult has suffered abuse or neglect should report that to the Cabinet for Health and Family Services. Under this particular statute, it was sort of weird that adult was defined as a person regardless of age, so it could theoretically be a minor who is a victim of abuse or neglect by their spouse. So clearly the intent of the law was to try to provide something to an individual who was experiencing spousal abuse or neglect. So that law, the stated purpose under the statute was to identify victims of domestic violence inflicted by a spouse and provide protection for those who choose to access the services. So our new law has a new stated intent. So KRS 209A now, the intent is to identify victims of both domestic violence, which is broader than just spouse abuse, and dating violence, to link those victims to services and to provide protective or therapeutic services to those who choose to accept them. So it's a little bit different than the old purpose. So as we went through the legislative process and we spoke to stakeholders who were, of course, curious as to why the State Domestic Violence Coalition was supporting this change in the law, we had to explain to them that really, in essence, the law that we had wasn't working very well, and it was very outdated when you compared it to how things were happening in the year 2017. So the first mandatory reporting of spouse abuse laws were enacted in 1978. And for those of you who've been around a really long time, you may remember that, you know, for many years, domestic violence, spouse abuse was something that was kept private. It was kept in the home. People didn't talk about it. Law enforcement often didn't respond to it. And there weren't a whole lot of services for victims out there. So the beginning of the domestic violence movement was really individuals who wanted to provide like safe houses for people who were trying to get out of abusive relationships, etc. So back in the day when these laws were first passed, the Cabinet for Health and Family Services was really took point on providing protective services to victims of spouse abuse. At that time, there was only one domestic violence program in Kentucky. And so you can see that there was an awareness situation, a problem with people being aware of domestic violence in general. There was a lack of services. And so the Cabinet, which was statewide, it made sense to house protective services with them. However, in the intervening 40 years, almost, we have had a greatly expanded system of services for domestic violence victims. And so, as I said, we have one program in each area development district, and they serve all the counties in that district. They provide both residential shelter services and also a whole bunch of other non-residential services to victims. And actually, since 1978, statutes have been enacted which designate our regional domestic violence programs as the primary service provider for victims in the state. And I can explain to you that the Cabinet for Health and Family Services contracts with my organization, KCADV, to provide those services in all 120 counties. And we subcontract with each one of our member programs to provide services in that ad. So the Cabinet has, by and large, passed along that obligation to provide services to our local programs. And what we've found over the years, of course, is that, you know, leaving an abusive relationship, it's a process. It's usually not a decision that's made on a day and the victim's able to just simply get up and escape everything and have everything in place for them to make that leap. And because it's a process, sometimes victims will disclose the abuse at a point in time way before they are ready to try to make that separation from their abusive partner. And a lot of times when they're making that disclosure, it's to someone that they think would keep that information very confidential. And in fact, it might be very dangerous if, in fact, once the disclosure is made, that it gets out that the victim has been talking, revealing what's going on in the home. If the abuser is to find out about that, it could really increase risk of harm for the victim. So there was a researcher at UK who we asked to do some surveys, and she found that 35 to 50% of victims would be less likely to disclose abuse to any sort of provider if they knew it had to be reported to the Cabinet. So that's what the law was, is that if you disclose to your doctor, your nurse, your therapist, your counselor, even your pastor, anybody, it was a universal mandatory reporting law. So everybody in the state, if they found out or had a reason to suspect that someone was being abused by their spouse, legally, they had to report that to the cabinet. And so this research proved what we already knew, is that that makes victims very uncomfortable. And it's very disempowering, too, because it takes decisions out of their hands and basically says, you don't know what's best for you, we need to report this to the cabinet. Kentucky, when this law was in effect up until June 29th, we were the only state in the country to have this type of law. So most states across the United States do have reporting requirements for certain types of injuries. If someone comes to an emergency room and it's a injury inflicted by a firearm or something like that, there are requirements that that be reported to the police because that's a community safety issue. But even a lot of states had laws like that, allowed for an exception for domestic violence victims. If they didn't want that reported, then they had that choice. So Kentucky has been forever the only state in the country that had this universal reporting law. Even against the domestic violence victims' wishes, it still had to be reported. And as I said, anecdotally, we have heard in the domestic violence advocacy community of situations where when a disclosure was made by a victim and the professional had to report that to the cabinet, that the abuser, who then found out, took retaliatory action against the victim. Obviously, that didn't happen every time, but it did happen enough that we would hear about it from time to time. So it did have a tendency to potentially increase risk of harm, which is exactly the opposite of what we wanted the law to do. We want to protect victims. And in the same research project, we also went to therapists. So we didn't go to physicians that were providing health care in hospitals or doctor's offices, but we went specifically to the mental health care profession because we had heard from them the most that the mandatory reporting, when they're trying to foster a therapeutic relationship with the victim and get them to be forthcoming so that they can actually provide some effective interventions or services, that if they had to stop that conversation and say, uh-oh, you just told me that, your spouse has been abusing you, now I have to report that to the Cabinet for Health and Family Services. And that just had a really chilling effect on their relationship with their client. So again, as a society, we want victims to reach out for help. We want them to be able to do that sort of in a confidential manner, and it really backfires when then that professional has to, sort of rat the client out if the client didn't want that to be reported. And we also found out that most therapists already knew how to make a good referral to our local domestic violence programs, to our rape crisis centers. And as I'll talk about in a minute, that was typically going to be the result of a report of abuse to the Cabinet for Health and Family Services. Because as I said, they no longer actually provide a lot of direct services to victims. So if they get a report and they're able to contact the victim, typically what they will do is be making referrals. And so that was already happening within the mental health care community. So the last thing we did was we went to the Cabinet for Health and Family Services and asked them if we could look at their data about reports of spouse abuse. So this is not child abuse, this is not abuse of vulnerable adults, this is just spouse abuse reports. So the year that they were able to let us look at, and subsequent to this slide, we've also been able to look at the data for 2015, and it falls right in line with the data that's on this slide. So in 2012, the Cabinet received approximately 40,000 reports of spouse abuse. All right, and so when we think about what does the Cabinet do when it gets a report, well, they're going to try to contact the victim, the alleged victim. And how are they going to do that? Well, I think it's a good thing that they typically did not try to go out in person and find the individual, because again, that can be very risky for that person. If their batterer didn't know that they've made a disclosure, it would be a little bit awkward to have a social worker show up on their doorstep. So typically the cabinet was trying to reach out through phone calls, if they had a phone number, or through letters, if they had a mailing address. And as you can imagine, a lot of reports, when they're made, the person making the report doesn't have that information. They might not have a good phone number for the victim. They might not have a mailing address for the victim. If somebody is a victim of domestic violence, they are often in a state of transition. They are moving. And this is 2012 data, so everybody think about your own cell phone. And if you get a phone call and it shows up on your little caller ID and you don't recognize the number, typically are you going to pick that up? Probably not. So there are a lot of reasons why. We found that of those 40,000 reports that were received, approximately 50%, so 20,000 alleged victims, there was never any sort of contact between Adult Protective Services and the victim. So right off the bat, even though somebody felt like they had enough information that they had to report to the cabinet, that 50% of those victims never had any contact, and we don't know if they ever received any offer of services or knew how to contact, how to access services in their area. So of the 50,000 who were contacted by the cabinet, so again we're talking about 20,000, approximately 20,000 victims, approximately half of those didn't want to receive services. And so again, the law has been, the report is mandatory, but the victim does not have to accept services. So you might ask yourself, well, why would a victim not want to receive services? And again, that's a very complex issue because many victims aren't at a point where they're ready to leave the relationship. And many victims are very leery about having the Cabinet for Health and Family Services get involved in their life because that can cause a lot of complications and negative repercussions for them, especially if there are children involved. And so obviously very few of these 40,000 reports resulted in someone being contacted and saying, yes, I want services. And for the most part, if they did say they were interested in services, they received referrals. They received referrals to community resources, including our local domestic violence programs or perhaps the local rape crisis center, amongst other places. And so it was rather circular in that the report was being made to the cabinet and the cabinet was reporting or making referrals right back to our local programs. And so the data showed that in October of that year, out of the 40,000 reports that had been received, there were approximately 40 open domestic violence cases. So you can see that really the system that we had that was put in place in 1978 had changed dramatically for a lot of different reasons, and we were just very fearful that victims who were being identified were just really falling through the cracks and were not getting useful, timely information about how they could access services. Also, they weren't given the choice as to when to access those services. And so those are the reasons why, for a while, KCADV and other stakeholders in the domestic violence advocacy world were interested in getting this mandatory reporting law changed. All right, so we're going to switch gears now and we're going to talk about, okay, well, what is the new law? So as of June 29th, this is the mandate that certain listed professionals have, and we'll talk about who falls under that definition in a moment. But if a professional has a reasonable cause to believe that a victim with whom he or she has had a professional interaction has experienced domestic violence and abuse or dating violence and abuse, the professional shall provide the victim with educational materials related to domestic violence and abuse or dating violence and abuse, including information about how he or she may access regional domestic violence programs or rape crisis centers, and information about how to access protective orders. So that's the mandate. So mandatory reporting has changed to what we're calling mandatory education or mandatory education and referral. So what are the professions that have this obligation under the way the law is now? So here's the list. I'm not going to read it for you, but you can certainly see that nurses are listed on there, in addition to many other professions in the healthcare field, the mental health care field, the Cabinet for Health and Family Services, child care personnel, teachers, ministers and their equivalents, and victims advocates. So it's a pretty broad list, but it's certainly much narrower than our old universal, everybody in the state has the obligation to do this law. All right, so we talked about the obligation being triggered when that professional has reason to believe that someone is a victim of domestic violence and abuse or dating violence and abuse. And so, you know, many people can conceptualize that word victim in different ways, and anyone who's in the domestic violence advocacy world knows there's many, many different ways to victimize somebody. But the statute directs us to the definitions that are used in our protective order statutes. Okay, so who are we talking about here? We're talking about an individual who is or has been abused by a spouse, a former spouse, or an intimate partner with whom they live or have a child in common. Okay, so that's our definition really of domestic violence and abuse as it relates to intimate partners. And then the second bullet is our legal definition of dating violence. So an individual who has been abused, is or has been abused by a dating partner, and under our protective order law that's defined as, the dating relationship is defined as one of a romantic or intimate nature. So that's kind of broad. I think it's one of those things that when the individual tells you, yes, this occurred and it was perpetrated, you know, by my boyfriend, by my girlfriend, you know, yes, we're dating. Those are the type of things that you're going to look for. And, you know, I can always encourage people that, you know, if you're not sure whether this relationship falls within this category, to err on the side of caution. Give the information anyway, because what we're switching to is the provision of information in a very confidential manner. There isn't going to be a report to the cabinet. There's not necessarily going to be a report to law enforcement unless the victim wants you to report it to law enforcement. And so if they don't want the information, that's fine. You can offer it to them, and you will have done, you know, your duty to act in good faith in regards to this law. And I would think that most professionals that we've listed there in that definition of professional, that you would want to try to help somebody who you felt had been abused by a partner. All right, and again, what's the definition of abuse? So again, there's many, many different ways in the domestic violence advocacy world that you can define abuse, but we are referring to abuse as it's defined under our protective order statute. Okay, so this is what you'd be looking for. If somebody has suffered a physical injury, a serious physical injury, they're being stalked, or there's been some sort of sexual violence or an assault. Additionally, anytime somebody inflicts fear onto somebody that they're imminently going to be hurt or sexually assaulted, that's also considered either domestic violence and abuse or dating violence and abuse. Again, if you want to err on the side of caution and go beyond that, and you're hearing about financial abuse or anything that may not fit very neatly under this category, you're always free to give that information to that individual. But this is the requirement of the law. This is the definition that we're using for abuse under this new statute. All right. So at this point in time, if you're one of those listed professionals, you now know that you have this obligation. And if you have this reason to believe that this person that you're working with, that you've had a professional interaction with, is a victim of domestic or dating violence and abuse, then you have to give them something. You have to give them information. Now, could you potentially do that verbally? Yes, you could. We're encouraging people to make sure that they do it in some sort of written form. And we are also encouraging professionals to document that they have, complied with the requirements of the law. And so in your organization, you might want to think about, how that's going to be accomplished, whether that's a notation in the chart, et cetera. It's going to be different for different professionals. It's going to be different depending on what type of a work environment you're in. But at KCADV, we have come up with one brochure that satisfies the 3 requirements at a minimum. And that's one of the handouts that's been provided to you in addition, along with this presentation. And you can always access it on our website. And so there's our address there on this slide. And that one brochure gives the individuals some information about domestic and dating violence and abuse. It has a copy of the map that you also have a copy of that shows where our local domestic violence and rape crisis centers are, and contact information for them. And it talks a little bit about the protective order process. If you are dealing with somebody who seems to be interested in trying to obtain a protective order, I've also provided, as one of the handouts for today, our protective order brochure, and that's also accessible on our website. So if you go to our website, on the home page on the left, you'll see a link that you can click on that says something like professional information for KRS 209A, and that's what you click on, and there's a lot of resources on that page. Obviously, a professional, if they have the time and the inclination, they can give as much information as they want. They can call the local domestic violence program or the local rape crisis center while that person is still with them. You can go the whole 9 yards, and that would be great. But sometimes we understand people are not going to have that much time. And so the one brochure, if nothing else, if you can give that out, you can download it and print it off right from our website. It's designed to be printed on legal size paper, but if all you want to do is print it on 8.5 by 11 and just hand it out as a one-pager, that's absolutely fine with us. All of our local programs have websites, and so if you know what your program is in your area, you can also go to their websites, and they'll have the same information and perhaps some additional more localized information about resources in your community. All right, so again, as of June 29th, there's no longer any reporting of spouse abuse to the Cabinet for Health and Family Services. If the victim that you're working with wants you to report to law enforcement, then it is a mandatory shall. The professional shall make the report to law enforcement after discussing it with the victim. Make sure the victim understands what the possible repercussions are for making that report. Also, if a professional has been working with someone, they've had a professional interaction with them, and then that individual dies, and the professional has some reason to believe that that death is related to domestic violence or dating violence, then the professional has the obligation to report that to law enforcement. And this was put in the law to sort of help professionals get around like HIPAA requirements or anything that might, put a barrier to them being able to be open with law enforcement about the information that they have. There is a provision in the law that if you act in good faith, in compliance with the law, then you should have immunity from either civil or criminal liability. However, just like the old law, when we did have mandatory reporting of spouse abuse, violation of the law is a Class B misdemeanor. Okay, and so legislature put that in to give it some teeth to make sure that, we hope that professionals want to help the people that they're working with. We understand that sometimes it can be dicey or there's not enough time or whatever, but we really want to try to get useful information into the hands of the victim quickly, confidentially, and then let them make the decision about when they want to access those services, when it's safe and appropriate for them to do that. And I do want to point out that this only applies to someone that you have a professional interaction with. There's not a definition of that under the statute, and so that might look different for, say, a priest than it would for a nurse. There have been some questions in the past about, I'm not at work 24 hours a day, so if this information comes to me via some other source, a friendship or someone I just run into or a family member, do I still have this obligation just because I'm a professional? The answer to that would be no. It has to be someone that you've had a professional interaction with. Okay. Here's the duties of law enforcement. I won't spend too much time on that. They aren't listed as professionals, but they have their own set of statutory requirements that they have to fill out, something called a JC3. They have to provide assistance to the victim, and that could include transporting them to get medical treatment. They have to advise the victim of their rights. And so again, law enforcement should also be giving basically the same information to victims that they're interacting with. I'll skip over that one. All right, so again, to emphasize, House Bill 309 did not change anything in regards to the mandatory reporting of child abuse, dependency, or neglect, or the abuse, neglect, or exploitation of a vulnerable adult. So we're going to run over those laws that haven't changed, just as sort of a refresher course. And I believe in your handouts you have a mandatory reporting quick sheet that's been updated to reflect what the mandatory laws are now. So child dependency, neglect, and abuse, it's housed in KRS Chapter 620. It is a universal reporting requirement with two tiny exceptions. Any person having reasonable cause to believe a child is dependent, neglected, or abused shall immediately report it, orally or in writing, and you have an option. You can report it to local law enforcement, Kentucky State Police, the Cabinet for Health and Family Services, or one of your local prosecutors. Most people, by far, will report it to the Cabinet for Health and Family Services. Here's the definition of a dependent child, because a lot of people aren't familiar with that term, but basically it means when the parent cannot care for the needs of the child through no fault of their own. So they're not actively neglecting the child, but there's something going on with the parent that's preventing them from giving adequate care. Say, for instance, a parent has a significant mental health issue and they go through an episode where really they're just not functioning. So they're not really trying to neglect their child, they're not purposefully neglecting their child, but that child might become dependent, and that needs to be reported to the cabinet or local law enforcement or local prosecutor's office. Those are the two exceptions to the child abuse reporting law. So if you're an attorney or if you're a clergy person, you don't have to make that report if the information came to you via that privileged communication that you have with your client or with the person that's coming to you for spiritual guidance. An abused or neglected child, this is a long, complicated definition, so I'll try to go through it a little bit slowly. So first of all, we look at it as it's not every time a child gets hurt, but typically there's a relationship between the child and the adult that's abusing them or neglecting them. And so the core of the definition is a child whose health or welfare is harmed or threatened with harm when their parent or their guardian, or someone who has custodial control or supervision of the child is doing something or not doing something, to make the child abused or neglected. They've thrown in now this person in a position of authority or special trust. I think this came about from all these cases that we hear about in the news where somebody placed themselves in a position, maybe they were a pastor, maybe they were a teacher, maybe they were a youth guidance counselor, and they had access to children and perpetrated against many children over the course of years. And so sort of as a reaction to that, there's been this movement to make child abuse reporting laws broader. So even though that person isn't a parent or a guardian, that would still have to be reported. And here's a definition of position of authority. So you can see there's this long list. It's not exclusive. But so those are the individuals that we're getting at. So if one of those persons is abusing a child, and typically it's going to be sexual abuse, that has to be reported. That's a mandatory reporting situation. And here's the definition of a person in a position of special trust. Again, you can see that we're getting very broad, so even though I start off by saying not every time a child is hurt does it need to be reported, we're getting closer and closer to that point with our laws. All right, and so there's a laundry list of the way a child could be abused or neglected, and I'm not going to spend a lot of time on this, so you can look through this yourself, but basically physical injury, emotional injury, either inflicting it or allowing it to be inflicted, or creating that risk that the child will be injured. Here's the definition of emotional injury. So, that's something that has to rise to the level of a substantial and observable impairment of the child's ability to function, as testified to by a qualified mental health professional. So that's a pretty high standard, and I'll talk about that a little bit more as we talk about reporting child abuse after the change in the law about we're no longer reporting spouse abuse. So again, there's this list of ways that a child could be abused or neglected. So basically neglecting care, anything having to do with sexual abuse, sexual exploitation, prostitution, abandoning the child, not providing the things that the child needs, and the last one is failure to make progress on a case plan. All right, and then there's some add-ons here. Like I said, this is a long, complicated definition. It covers a lot of ground. But anytime there's sexual abuse, exploitation, or prostitution of a child, when that child is less than 16 and the perpetrator is 21 or older. And the definition of sexual abuse is very broad. It doesn't mean somebody held the child down and forcibly raped them. It's any time that there's the use, allowing, permitting, or encouraging the use of the child for the purpose of sexual stimulation of the perpetrator or another. So that could be what in the child, the younger party's mind, is a very consensual relationship, and that's what they want. They're 15 years old and their boyfriend or girlfriend is 21, 22, 23, 35, whatever. That's sexual abuse, and that would have to be reported as child abuse. Additionally, any child that's suspected of being trafficked, anyone under the age of 18, that has to be reported. And trafficking, when the person being trafficked is a minor, it's any time there's prostitution or a sexually explicit performance. There does not have to be any force, fraud, or coercion involved, or it could be forced labor. So people probably don't think about that as a reportable type of child abuse. But if someone's under 18 and they're being forced to work through force, fraud, or coercion, that would have to be reported because they're potentially being trafficked. Again, if you are supposed to report and you don't report, it is a crime. So it's a Class B misdemeanor for the first offense, and the penalties could go up if you had subsequent offenses. And there have been some prosecutions under this law. This is a pretty old one, but this was a situation where two people in a school knew about a teacher that was sexually abusing a student. They went to the principal and sort of left it up to the principal to make the report, and the principal didn't make the report. And so then, of course, we know what happens. The teacher reoffended against another student, and everybody was very upset because the school knew about it and no report had been made. So all three, the teacher, the guidance counselor, and the principal, were all successfully prosecuted for failing to make a report. And there is a part of the child abuse reporting law that says if you are a supervisor and someone comes to you, one of your employees that you supervise, and then by what they tell you, you also have a reason to believe a child is abused, neglected, or dependent, you have an independent duty to make that report. Okay? All right. So I did want to talk a little bit about what we have had some questions on, because now we're not reporting spouse abuse to the cabinet. So some people are concerned about, well, what if there's domestic violence in the home and there are children in the home? do we now have to report that as child abuse or neglect? So I can refer you back to the series of slides that talk about, well, what is an abused or neglected child? And I think a lot of times people posit the potential reporting of that situation on this child is experiencing an emotional injury, or domestic violence is bad for children. And yes, we know that. We all would agree 100%. However, you have to think of what happens when a report is made. It gets to the cabinet sooner or later. They're going to do an investigation, and if they substantiate abuse or neglect or dependency, then there is the risk of removal of that child. And not just removal from the parent that's creating the violence in that family, but from the parent who we sometimes will refer to as the non-offending parent. And there are studies that show without a doubt that, one, it's very detrimental to children to be removed from a non-offending parent. And two, that the best results for children who have experienced trauma of any kind is really to try to foster and support a bond that they have with a caring adult, with someone who's been a primary caregiver. So we're just encouraging everybody as we move forward with this new law, the way the law is now, to, you know, sort of think critically and not take the knee-jerk reaction of, well, I can't report this as spouse abuse anymore, so I'm just going to report it as child abuse because, you know, there's domestic violence between the two adults in the home and there are children in the home. So we would encourage people to think about additional risk factors, to really thoughtfully make a decision about whether they think that that child is at risk for physical injury or emotional injury. And we are encouraging everyone, if you are in doubt, report it and let the Cabinet for Health and Family Services sort that out. It's not your job to investigate. It's not your obligation to make that investigation. But before you do make that report, you know, make some time to consider whether that's really appropriate in the circumstances that you know them to be. Okay, so we're getting a little bit short on time, so I'm going to kind of scoot through this one. So we have another mandatory reporting law, and it's a universal mandatory reporting law. So everybody has this obligation in the state of Kentucky. If you have a reasonable cause to suspect that an adult has been abused, neglected, or exploited, you have to report that to the Cabinet for Health and Family Services. Now, under this statute, adult has a very specific definition, and that is someone who actually is an adult, 18 years or older, who has a mental or physical dysfunctioning, which I like to say that's going to be either a mental or physical disability, and in addition to that, they're unable to manage their own resources, carry out the activities of daily life, or protect themselves from an abusive or exploitative situation. So it's not just everybody who has a disability, because obviously some people with disabilities are fully capable of making those types of decisions for themselves. And then you have a whole spectrum of people who are going to get to the point where really they are not able to take protective action to get themselves out of an abusive situation. Here's the definitions under this statute for abuse, for neglect. Those are very, you know, commonsensical definitions. And then we throw in here exploitation, which is financial exploitation. So unfortunately, many individuals who have a disability are at extreme vulnerability for being exploited, because either they're receiving benefits, benefit checks, or they have to give somebody power over their finances, and then that person may easily be exploiting them. So that also is a mandatory reporting situation. All right, and then the last, this is not really a mandatory reporting law because it doesn't apply to everybody across the state, but we do like to mention this one because we get some questions on it frequently, and that's the duty to warn. So these laws sprung up across the country in response to situations where someone took a whole bunch of guns and went someplace and killed a whole bunch of people, and after the fact, it may have turned out that, oh, that person was receiving mental health care services. Why didn't somebody know about this? Why didn't somebody tell the authorities that could have prevented this act from happening, which I'm not sure that any of us believe that's really possible, but that's sort of the genesis of these types of law. So under KRS 202A, which deals with adults, and KRS 645.270, which deals with juveniles, if a professional or if a qualified mental health professional receives, hears, knows about an actual threat of physical violence against a clearly identified or reasonably identifiable victim, or an actual threat of some specific violent act, then they have a duty to do something. Okay? And that duty is to make reasonable efforts to warn the victim, notify the police, and possibly seek a civil commitment of the individual that's making those threats. And this can also include threats of harm to themselves. So that's why if you walk into an emergency room and talk a lot about how you're going to commit suicide, they're probably not going to let you just walk out the door, because they have to make these efforts under these laws. And this part that says an actual threat of some specific violent act, that's a little bit vague, but this would be a situation where the person's not saying, you know, I've got, you know, a gun in my glove box and it's loaded, I'm going to drive to my ex-spouse's house and I'm going to, you know, break in the door and shoot that person. This would be where they're saying, you know, my car is full of firearms and I'm going to go to the McDonald's on Main Street, I'm just going to start firing. You know, so those two type of situations would be what would trigger this duty for the qualified mental health professional. And so what does that mean? So there's a list of who falls under this. And the one reason in particular for this presentation is you can see a physician, a psychiatrist, a psychologist, but this top one, a registered nurse who's engaged in providing mental health services. So that may apply to some of you in the audience. Social workers, marriage and family therapists, professional counselor, art therapist, fee-based pastoral counselor. Also, when it comes to a juvenile, there's this really nebulous language that says anyone acting in the role of a counselor. So I've been asked, like, well, what does that mean? And I have not been able to find a legal definition of that anywhere. So can't give you any really good guidance on that. But so if you worked in a juvenile facility and somehow you could be perceived as a counselor and threats were made, you know, to you, you would have these same duties, just as if you were a psychiatrist or whatever. Okay, so we have just a few minutes left, and you know, we really do want to encourage all professionals to think about screening for domestic and dating violence. And why do this? Well, obviously, when you don't ask the questions, people are often not going to just volunteer the information. And we're really happy that now, if you do ask the questions, your response isn't, oh, wait, I got to go call the Cabinet for Health and Family Services. It's going to be, great, here's some information I can share with you. And then the person gets to decide, you know, when and where they are going to utilize that information. Screening has to be done thoughtfully. I'm sure all of us have been in an emergency room where they're ticking off questions, just going down a list, tick, 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 and one of them's going to be, do you feel safe in your own home? And I personally have been in an emergency room with like my young adult daughter, with my aged, you know, mother, both of whom had, you know, injuries, and, you know, it's like, well, I could potentially have been the abuser, right? And so, you know, we want to do that thoughtfully. And encourage organizations to think about what would be the appropriate questions to ask, and how and in what circumstances would the questions be asked. Optimally, you want to do this screening with the person on their own, with nobody else in the room. This can be a huge issue if the person doesn't speak English, or perhaps they're deaf, or have some other communication issue. And who do you want to use to interpret for them? It's the family member that brought them in. And I guarantee you that sometimes that is going to be a batterer. So we have to be thoughtful about that. So we like to use this SAFE model. asking people if they feel safe in their relationships. Has anyone hurt you or your children? Are you afraid of your partner? You know, would anybody know about the abuse? Would they be able to help you? And then some safety planning. And if you as a professional don't have the time or don't know how to do safety planning with someone who's disclosed abuse to you, that's when you really need to be making that referral to somebody who does know how to do that. So don't just let the person walk out the door and go home with the abuser, you know, and you don't know what's going to happen at that point. So here's some example screening language. You can look at that. You know, and trying to make it very blanket approach. Like, we always ask this question to everybody. And I can't tell you as an attorney, having practiced for 30 years, how many times I've had clients say, yes, they went to an emergency room, and no, they did not disclose the abuse, even if it was the direct cause of the injury they were seeking help for. And I think a lot of times there's a lot of reasons for that, but one big reason might be that no one ever asked. Or they didn't feel safe answering that question because of where it was asked or how it was asked. So let's see. Like I said, here's just a screenshot of our website, and someone took this screenshot before we had the information up, I guess. But over on that bar to the left, that purple bar, about halfway down, you're going to see KRS 209A information for professionals. You click on that, it's going to take you to a page where you can download this brochure and a lot of other information. Making screening, making referrals. We would hope that people would be able to do this. We realize people won't always have time to do it. But there's some suggestions for how to make a good referral. We also have a brochure on protective orders, so that's one of your handouts. You can download that from our website. We also have like 1,000 of them at our office, so you can always contact us. We'll send you some. Here's some additional links to resources if you want more information, if you want to share this information with people that you're working with. And there is myself and a couple of my colleagues. If you have any questions, you can always shoot us an email, give us a phone call. If there's anything that you think that we missed in this training presentation that you think would be helpful, you know, for audiences in the future, we'd love to hear from you. And I know that we have someone in the back that was going to kind of look for questions. Is there anything I could answer really quickly? No questions.
I have a list.
Okay. All right, so Joy has a list of questions.
First of all, thank you for an excellent presentation,
Welcome.
Meg. Appreciate it, and very timely and relevant to public health nursing practice. One, I wanted to ask you, you had mentioned before our presentation that there was a link that someone in the cabinet had developed for more information from DCBS perspective, and you'll send me that link. Could you just mention that?
So there actually is a recorded presentation with a PowerPoint done by somebody who works with Child Protective Services that is focused just on the reporting of child abuse and neglect. So that's hosted on the CHFS website. There's also, I think, either a pamphlet, a brochure, a handout of some sort, a booklet that you can download and look at or hand out. So I'll send Joy the links to those so that if anybody wants some more information sort of about the cabinet's perspective on child abuse reporting, then you'll have that to look at.
And for the audience, I wanted to share that we'll be, not in addition to taping today's 3-hour webinar, we'll be pulling out Meg's presentation as a standalone 1-hour taped presentation, archived presentation, for those of you all who want to share specifically this information with your other nursing staff, other staff within your local health department, or perhaps some of your community partners who may be interested and need to be updated on the change in law with House Bill 309. So that will be available to you all as soon as we can get that, as soon as we can pull that out and take that as a standalone piece of information. I also wanted to share, and this is more of a comment, not a question, but I did mention to Meg before her presentation that in the administrative reference, we currently have a chapter on abuse, neglect, and violence, and so I'll be working with Meg to update that chapter of the administrative reference to reflect this information that Meg has provided to us today. That information will include guidance about documentation of the education and any referrals that were provided to clients. So we'll have that guidance in there for you all, so you'll know where to document those actions. And then, Meg, for you, if a local health department would like to have their regional ad come and perhaps present on House Bill 309, or let me rephrase that, do they contact their ad district, their ad domestic violence shelter, or do they contact you all, or what's the best way to help you all get the word out?
That'd be great if we could. So yes, we have done train the trainer training for our local programs, so they should be prepared. So if you want to reach out to them first, that's fine. However, if you feel more comfortable contacting myself, just simply because you've seen this presentation, I'll certainly put you in contact with whoever at your local domestic violence program will be able to help you out. And we also are going around the state, you know, and talking to people here and there as we get requests. So either way, if you go again to our website, you can find contact information for all of our local 15 member programs. So if you don't know who your program is in your area, you can always find it easily there.
And I was thinking particularly with the Kentucky Department of Education and our school health nurses and the partnerships that local health departments have with their schools. I know that schools have, you know, regular professional development days, so forth and so on. So that might be a venue for local health departments to perhaps partner with their schools.
Right, and that would be really great because I don't know, we haven't really heard from very many schools in terms of how they are trying to implement this, because of course teachers and school personnel are considered professionals and have this obligation, and what we anticipate is they'd probably be able to hear about, they would be getting disclosures of dating violence and abuse.
Yeah.
So, great.
Thanks. Thank you very much. Thank you, Meg. You did an excellent job. Appreciate it. It's good to have a new partner in Frankfort. And appreciate you helping us get the word out to the local health department and public health nurses across the state. So what we're going to do, we've got a couple of updated PowerPoint presentations, the latest and greatest from this morning. So we're going to take just a couple minutes break. So if you want to go get your coffee refilled or get another Diet Coke, you've got just a minute to do that while Tony's switching out those PowerPoints. We'll be right with you. All right. Thank you, Tony. Okay, we're back from our brief commercial break. Next, I'd like to introduce Jim House, who is a master exercise practitioner, as well as one of our public health preparedness branch managers here within the Department for Public Health. And as I was planning for this webinar agenda, I realized that August 17th was 4 days before August 21st. So I picked up the phone and invited Jim and Doug. We'll introduce Dr. Thurman here in just a moment. Invited them to come and share with you all the planning and preparations that have been going on, both behind the scenes and through public communications, both at the department and at the local health department level. I'm sure many of you all, especially in the western part of the state, have been involved in those plans and preparations, but some of you may have not if you're not in that particular path of the eclipse. So I thought it'd be of interest to share with you all everything that's going on so we can all be knowledgeable and be prepared for Monday. So Jim, thank you so much for being here with us. And Jim and Dr. Thurman are going to kind of do a tag team approach with this time frame. So thanks to both of you all for being here today. Come on up, and it's all yours.
Good morning, everyone. My name is Jim House. I'm the Public Health Preparedness Branch Manager. And for the next few minutes, I'm going to be talking about the 2017 solar eclipse. We have a PowerPoint presentation and we have a short video, and we'll get moving here in just a second. Okay. So, just for your information, there has been a lot of preparedness activities going into the 2017 solar eclipse. We have been working very diligently with the folks at the local level, with multiple state agencies and emergency support functions, or ESFs. There are 15 emergency support functions that support the Division of Emergency Management, who is Emergency Support Function 5. And most of these will be activated to some degree during this, and they've all turned in plans for an incident action plan. So there's a large gathering or grouping of these incident action plans that's been put into a playbook by the Division of Emergency Management. So I'm saying all that to let you know that the seriousness of this is we've did a lot of planning with multiple emergency support functions, multiple local agencies, state agencies, and we've also got the Department of Health and Human Services, our Region 4 Emergency Coordinator, Jeannie Eckes, involved in this, who's on standby if anything should happen. So for the next few minutes, I'm going to go through my PowerPoint slides. I'm going to show you a short video, and then if you have any questions. So, just a quick overview. You've probably seen a lot of news articles. There's probably been some news reports on the 2017 solar eclipse, but the solar eclipse will occur this Monday. It's the first solar eclipse in 38 years for the contiguous United States. For Kentucky, it's going to impact 21 counties in the western Kentucky area, with Christian County and Lyon County having one of the greatest coverages for length of time, over 2 minutes and 40 seconds. So what that means is that it will enter into western Kentucky and go through the parts of western Kentucky, and the prime viewing area is in actually Christian County. And there's a small field out there, and I'll show you some pictures of it here in just a second, where the greatest viewing area is, and there's going to be about 3,600 people in that field. A farmer has rented this out, and there's going to be campers, and I'll get into more detail about that in just a second. But you'll see the total solar eclipse, and it's supposed to be a awesome viewing opportunity that happens very infrequently, and like on the slide, it was last 38 years ago. So at this time, I'm going to try, and hopefully this video will work. But this is a short video that will give you an overview of the eclipse, and hopefully it'll give you some more information that you have not had before. And that's why I said I will try, because I still see it. How do we get the video playing? No, it's embedded into the PowerPoint. We're working on this, folks.
That's what I was wondering. What was this going to play? Yeah. It's not letting us play it.
Okay.
Yeah.
Okay.
Okay. I'm sorry.
Okay, well, we've had a technical difficulty and we can't fix it at this time. So there is a short video out there that gives you an overview of the eclipse and the importance of the eclipse and how many people are coming to view the eclipse. There's a lot of scientists coming to do some studying. There's also weather balloons being put up into the air, so there's a lot of efforts going into studying the phenomena around the eclipse itself.
And Jim, if you'll send me that link, I'll be glad to forward it out to them.
Okay. So, in regard to the eclipse, there's been multiple ESF8 preparedness activities. We've had multiple meetings, and I could probably just sit here and say multiple a few more times. At the local level, Tina Massengill and her team out there have been doing many meetings with many counties, working with emergency management. Specifically in Christian County, emergency management has taken a very strong lead on this, and then the emergency managers in the other counties have been working very diligently with the Division of Emergency Management to get this, all our preparedness efforts into place. Through these meetings, we have conducted a threat health assessment, and I'll talk about that threat health, the threats here in just a second. But on July 12th, we held a large tabletop exercise where the Lieutenant Governor was involved. It had multiple agencies, well over 250 participants from 100 agencies, to include our Region 4 Emergency Coordinator, Jeannie Eckes. The scenario included a foodborne illness outbreak, waste issues on the farmland, threat of severe weather, and traffic management. So based upon those threats right there, they're really worried about the amount of people who are converging on this area. They're expecting anywhere above 350,000 people into a very rural area. And specifically where the event is that we're covering, there will be about 3,600 people. Some of the gaps that came out of that tabletop exercise is the gap that we've had for many years now is a patient tracking system that everybody is using and is on the same page. Right now we're using a variety of systems to include Excel spreadsheets. And then we don't have our Family Assistance Center plans in place. So if something did happen out there, this would be very hard to stand up. We could do it, but it's going to take some planning, quick planning. And my pictures, are the pictures showing up back there too? Okay, so we're having real technical difficulties. There were some pictures here on showing the fields and where this is all going to be located. Some of the public health threats that they're really concerned about is communicable disease outbreaks from food vendors. There's going to be a large gathering of food vendors. They are being inspected. There'll be a variety of foods served. But you know you're going to be out in austere conditions. We're going to be in rural conditions. We're going to be on the street. We're going to be at various locations. There's multiple festivals going on starting probably tonight, going into Friday, Saturday, and Sunday, even before the eclipse event itself. So we'll be providing ESF8 support from the state level beginning on Saturday. But out there, Tina and her team at the Regional Response Coordination Center, they'll stand that up Saturday, but I know they're providing support as we speak now. Another issue is the sewage and waste from the large gathering of folks in rural areas or at campgrounds. I mean, it's just a huge influx of people in an area that isn't used to having a large influx of people. If this happened in Louisville, it wouldn't be as much of an issue because they've got everything in place and they're used to these large gatherings, i.e. Thunder over Louisville or the Kentucky Derby. But out here in rural Kentucky, they need a lot of support. They have done a lot of planning, and that's what we're here for. Sewage may be a big important factor. Think Woodstock and all those people, and where did they go to the bathroom? Out there where we're having the gathering for the VIP general viewing area, they will have porta potties out there, but it is a field, and the only service that is out there is a fire hydrant. So think about that. And there's a couple barns too, so I guess they can go behind the barn if they want to. A lot of vectors that will be out there include mosquitoes. They're concerned about bed bugs. We're going to have a lot of visitors coming in, not only from other areas in the United States, but from other countries are coming in to visit. So all the hotels are filled, so they're concerned about the bed bugs. Ticks is another concern. So just think of all the threats. If you're in a rural area, you're out in a field, you're out in the woods, everything that comes with that. There could be dog bites, there could be animal bites, there could be snake bites, spider bites. So all that needs to be taken into consideration. The big thing that we're worried about is the heat and dehydration, especially if these people have been out in the various festivals over a 3-day period, and then they go out there and stand in the sun all day and they're dancing to the music and playing to the music and participating in the festivals. Hopefully there's enough water out there. We are supplying some water for our teams, and we do have emergency water for people who are seeking treatment, but water supply is extremely important. Soda isn't going to get it, tea isn't going to get it, it has to be water. Another thing is, another threat that they're concerned about is the numerous people who are going to be on the Kentucky Lake, and the Coast Guard is very well aware of this, and all the campgrounds are full. They're concerned about the number of boats on the lake and then the partying around the boats and all that kind of stuff. The big thing that I'm concerned about is if there's a mass casualty incident of any type. That's what we're primarily standing up for. If something does happen out there where there are mass casualties, and how you define that would be anything that would overwhelm the local medical system, that's where we're here to stand up and coordinate ESF-8 support. And we would coordinate with all the healthcare coalitions, health departments, emergency management agencies throughout the state, and if need be, then we'd reach out to our Region 4 states and the Department of Health and Human Services. So as you can see on the bottom of the screen there, the large influx of persons at that one area in the VIP general area at Orchard Dale Farm. There are campers. They're probably pulling in there now or tonight and beginning tomorrow. And then on August 21st, there's going to be about 3,600 people. They originally planned for about 6,000 people, but they've reduced the number down. And then just up the road, not very far from this, is something called Soul Quest, and that's a separate event. They have their own medical services, but if need be, we would stand by and provide support for them. They'll have over 10,000 people in another field with very limited services. So you can see right there we have, what, 13,600 plus people, and that doesn't include the responders who are going to be in a very rural area in a very small location. And then keep in mind there are other events happening in other counties, in the surrounding 20 counties. Just in Christian County alone, there's probably greater than 24 events happening. And then that doesn't include all the rest of the counties across the state. That's something else that we're monitoring as we go through this 4-day period. What other events are occurring and what other things could happen. So that's something to think about as we move forward. In regard to ESF-8 operations, you can see on the blue screen over there, we're partnering with a multitude of agencies, with the Kentucky Board of Emergency Medical Services having a direct impact on this operations. They've put together an incident action plan which outlines their operational period and their responsibilities, specifically for EMS operations. They will be at the Regional Response Coordination Center in Hopkinsville, Kentucky. That'll be Chuck O'Neill and Mike Pointer. And they'll be partnering up with the Department for Public Health at the RRCC, the Regional Response Coordination Center. And so they'll be coordinating emergency medical services and, if necessary, bringing in additional helicopters. They've identified strike teams with ambulance services, both ALS and BLS, and they've got helicopters on standby if necessary. We, as the Department for Public Health, are the lead for Emergency Support Function 8, along with our partnering agency, the Kentucky Board of Emergency Medical Services. So if anything does happen in that area or anywhere in the state of Kentucky, we can stand up operations and begin coordinating support. We have worked with local, state, and federal agencies, and I've said that time and time again, but this has been a huge, huge planning effort, many, many hours. And if you could attend KYEM's briefing, they've had 2 within the last week, the amount of operations that are going on are just phenomenal. It's just the state police, the Civil Air Patrol, the Division of Emergency Management, Emergency Medical Services, Transportation, the Kentucky State Police, it's the Department of Homeland Security, the Kentucky Office of Homeland Security. It's just multiple agencies. We have put together a very extensive incident action plan, and what that does is it outlines our roles, objectives, and responsibilities leading up to the eclipse, during the eclipse, and then our recovery phase. We are deploying people downrange to the Regional Response Coordination Center, and we are deploying people to the Orchard Dale Farm to set up first aid tents. As you can see here, we have, if you added those numbers up, we have 99 people identified alone in our IEP alone to support ESF-8 operations. This does not include all the health department directors, some of the preparedness personnel, the LHD nurses, the KDPH nurses. So this is only those people that have a direct role or who are on standby to stand up our State Health Operations Center. So you see the numbers there at the State EOC, the Regional Response Coordination Center, the Orchard Dale Farm, and at the State Health Operations Center. and you should have received an email today or will soon be receiving an email. As of 9 o'clock today, we have stood up our State Health Operations Center to level 4, and we are monitoring situations leading up to this event and events across the state. So if necessary, we do have a team on standby to fully activate the State Health Operations Center, and if we did that, we would bring Joy in, and she'd be coordinating very actively with you nurses. So, at the Orcharddale Farm, we have 2 first aid stations, and those are big Zumro tents. They're those tents that you can just blow up like a big balloon. And there's a red one and a yellow one, so they won't be hard to miss out there. And they're very, very large. We'll have a communications trailer provided by the Fire Commission. That'll be there for ESF8 coordination with the Regional Response Coordination Center and Emergency Medical Services, who are staged nearby those 2 events. And then for this event, we actually have 30 Medical Reserve Corps volunteers who will be providing first aid through those first aid tents, and then they'll be walking through the crowd, monitoring the situation, and monitoring the people looking for signs of sunburn, hydration, or any type of heat-related injury or dog bites, insect bites, that type of thing. And we can provide services, limited services, at those first aid tents. In regard to plans and people, our plans that we have got into place, as you know, over the past years, we have been doing all hazards emergency operations planning. And so we do have local emergency operations plan, and we do have the Kentucky emergency operations plan. For the Department for Public Health, underneath the emergency operations plan is the Emergency Support Function 8 Public Health and Medical Services Annex. And that's basically our framework for how we coordinate and provide ESF8 support during the preparedness, response, and recovery phases. Today I sent out a notification that we were activating the shock to level 4 that is outlined in the ESF8 Annex, so that now you have a site, a location, and contact information. If anything happens across the state, you can rapidly notify the State Health Operations Center or the Division of Emergency Management, and we can start providing support for ESF8 operations. Some other plans that directly impact our ESF8 operations are the State Health Operations Center Support Plan. That outlines our roles and responsibilities once we activate that. If something bad does happen, it is covered in the Kentucky Mass Casualty Incident Support Plan and all the agencies that have a primary and supporting role if we have a mass casualty event. The incident action plans, I mentioned this earlier, are gathered from each of the emergency support functions and are put into something called a playbook. It's a very large document, but it has all the emergency support function incident action plans from each of the ESFs into that one playbook. And that just provides emergency management and officials understanding of what agency has what responsibility and what roles during this event. And then we've been very big on public messaging. I know a press release was sent out yesterday, a coin alert was sent out yesterday. There's multiple videos talking about eye protection, sunscreen, heat injuries, Zika, hand hygiene, translation services, and other things. The important thing here is if you're going to view the solar eclipse, and whether it be partial or full, you need to be wearing your eye protection. Eye injury is possible, and it's not an immediate eye injury, it's a delayed time thing where you have retinal burns. So please wear your protective glasses and make sure they're ISO compliant. Some of the people and teams that we've been working with, you can see the list on the right, and that's not all inclusive, but that's basically for ESF8 alone. And like I said, we have been planning with multiple people, multiple teams, and multiple agencies at all different levels. Some of our operations and equipment, we're deploying 2 Zumro tents. We have 2 45 watt generators, Genowatt radiators, I like that, but 2 45 watt generators, 4 HVAC systems, so each of those tents will have 2 air conditioning units hooked up to them to help keep cool. So if we do have somebody with heat injuries, they can go into a cooler environment. We have ESF8 trailer out there that could be used as an alternate command trailer or could be used as a first aid station. And then we have a communications trailer with multiple equipment. There's also Kimpack in locations nearby, so if we do have a neurological agent that's dispersed, we do have the Kimpacks available there. Hand washing stations, I hope to goodness there are hand washing stations out there, because if not, we're going to have some big problems. And then we have our 13 regional healthcare coalition assets. If something does happen, we need additional assets to provide support to any area in Kentucky. The healthcare coalition coordinators are on standby to receive our request and, if necessary, to deploy those assets. And then on the bottom there, you see my little happy face. We have one fire hydrant out there where we can get potable water from. So we're going to also have trucked in potable water and bottled water. But that's the services that are in that field. So we're bringing our own, and we'll be a standalone operation out there. It can be fully functioning with generators, communications equipment, water, food, volunteers, staff, etc. In regard to situational awareness, we're going to use multiple systems. Our primary system that we will be using is KYEM's WebEOC. There's a lot of new ESF8 boards in that system, and that will actually go fully operational for us on October 1st, and DPH's WebEOC system will be shut down on September 30th. So, but right now we can use it. It does have functioning boards in it, and this is how we're going to maintain situational awareness, because all agencies in Kentucky should be using KYEM's WebEOC or be fused to this so that we can maintain situational awareness. If we have to send out an alert, our primary system will be the Kentucky Health Alert Network. So please make sure your up-to-date contact information is up-to-date in that. Another system which we're trying to roll out and which will be fully operational in about 6 months is ReadyOp. We have put in there all the health department ESF8 incident management personnel into the system, and that includes the health department directors, the PIOs, the preparedness coordinators, the epidemiologists, the nurses, which we're still working on, and I'm going to talk more about that here in just a second, and a couple other groups are in this system. This is a very inexpensive system, and soon it will take place of the Health Alert Network, and it's got a lot of capabilities, and we'll provide more training on that later. And then I encourage each of you to maintain situational awareness through the use of email, specifically to the SHOC email of chfsdphdOC@ky.gov. And then there's multiple communication systems, cell phone, cellular on wheels, those are called COWS. Verizon, Sprint, and AT&T are bringing in those COWS, or cellular on wheels. That just increases the capability of the wireless system in the area. We have satellite radios, telephones. We've got DMARCS radios, which operates through the Division of Emergency Management in the Kentucky National Guard. We've got communication systems that are being trunked in or connected to each other. So one type of radio can talk to another type of radio. So you're not really concerned about the different types of radios that you have. They'll all be trunked together, and they should be able to communicate throughout the event. In the worst case scenario, if all systems go down, we do have ham radios, and there are ham radio operators on standby. They will operate in almost any type of environment. We've got UHF, VHF radios. All my staff have GETS cards, and what that does is it allows you to get ahead of everybody else in the queue. So if the phone system becomes overwhelmed, we put in our code. If we were at the back of the line, then we move to the front of the line. So, and then we're also looking at getting that for wireless. And then I don't even know what's out there, but there's multiple agencies with multiple communication trucks, trailers, antennas, equipment. They'll be at the Regional Response Coordination Center. They'll be staged near the event locations. I know it's going to be huge on communications. Before I leave this slide, I'm going to go back to the ReadyOp. We do have the LHD supervisors loaded up into ReadyOp, but not everybody is current in that system. So what I'm going to do is probably this afternoon, I'm going to send out an email back to you. Please look out for that email and click on that link and update your contact information in ReadyOp. And what this does is it allows us to rapidly notify and share information with you. And then, like if we wanted to get a text message out, an email message, or a phone alert, we can do that. And we'll just work with Joy to do that. But please update your contact information in that. So in summary, public information has been a very key component of this. We need to get the word out that it's not safe to go out there and look at the eclipse with the naked eye. You must have protective eyewear. And the other factor is dehydration. Stay hydrated, especially if you're involved in those activities out in Western Kentucky or anywhere, and you're out in the sun all day. It's very important to stay hydrated. Food safety, we do have an environmental team out there conducting multiple inspections to ensure the safety of our food supply. Vector control, we're working with the Department of Ag. They're doing some spraying out into those field areas, and hopefully that'll reduce some of the insects and pests that are out there. Some of the concerns that we're worried about is the large gathering of people and the amount of trash that will be generated and the amount of waste, whether that be human waste, food waste. You can use your imagination there. Command and control. We do have command and control at the site where we have our first aid stations. We do have command and control at the Regional Response Coordination Center in Hawkinsville, Kentucky. And we do have command and control at the State Emergency Operations Center. And we have our State Health Operations Center at level 4 with a team on standby. Communications, I just addressed that. We have multiple systems and multiple ways to share information and communicate. If an alert does go out during this weekend, it will be for real. It will not be a test alert. So you need to answer and confirm your alert and then stand by for further word. We're also doing disease surveillance out there. We're coordinating with emergency medical services, hospitals, local health departments, and the first aid stations to look at the disease trends, look at the injuries, the reportable cases in the first aid tents, and if necessary, we have an EPI strike team that we can activate and deploy out there to provide assistance. Medical surge is another big issue that we're concerned about. The hospitals are aware of what's going on. They have planned for a medical surge event. K-Beams is planned for a medical surge event, and if that happens, we will stand up our shop and start providing ESF8 coordination and support to all local areas throughout the state. First aid stations will be on scene. They'll be providing support to the participants. And also another thing that we've addressed as a high priority is if a child gets lost and separated from the parents and they report to the first aid stations, we have procedures in place to notify local law enforcement and coordinate that. And then last but not least, this has been a big event for us because the Medical Reserve Corps volunteer has been activated, deployed, and they'll be providing services during this event. And we're very excited about that. So this should be good. So, sorry about the pictures and the video. That was a good video too, Megan.
Again, if you'll send me that link, I'll zap that out to them today.
Okay. And then my last slide, and
you go right ahead.
Oops, my last slide, that's all right, is on demobilization. Just be aware that we have prepared for this. We're sending people downrange, and then when they're downrange, they're doing the operations. And then we have to plan to get them back safely. So all our people are communicating through all this transition as they're moving downrange during their operational period and then getting these resources back, and then we have to bring these resources back to an operational status.
Thank you, Jim. Yeah. Thank you, Jim, for you and your team and DPH and local health departments and all of our partners across the state. What a huge coordinated effort, and I'm sure everything will go off without a hitch on Monday. Okay. Thank you for coming. Next we have Dr. Doug Thurman, who is a CDC career epidemiologist, and we're so glad to have him here within Kentucky's Department for Public Health. He's going to be talking about, from the EPI perspective, the preparedness information and planning that has gone on for Monday's event. So Dr. Thurman, I'll turn it over to you. Oh my gosh, he's got his sunglasses on.
So I can't see a darn thing, but I am prepared for the eclipse. So, if you have the right glasses, you can't see anything except the sun. So anyway, good morning, everyone. So as Joy said, I'm from the Centers for Disease Control, but if you've been here for a while, you've seen me probably because I've been here for a while, since 2002, and I'm actually the Deputy State Epidemiologist now, even though I'm a federal assignee, and so I do a lot of functions here in Kentucky. But one of them is working on a lot of preparedness stuff. So I want to talk about the Rapid Response Team end of what we're doing here, and if I can bring the slides up, that would be great. My trusty assistant told me it's ERRT. Where is it? There. All right. So my first slide may have no pictures on it based on Jim's experience, but we'll see. So am I going down? Oh, by golly, does it show up? All right. So my pictures are there, Jim. I don't know what happened to yours. Anyway, I just did a quick search of the internet yesterday, much to Joy's chagrin. I was putting my slides together at the last minute, and this is just the first 5 websites I came to. There's just so much information on the internet about come see the eclipse and come be part of this and get your glasses and all this other stuff. And so it has been highly publicized, and that's why we expect a lot of people to be down here. The question is, this is a once-in-a-lifetime event, but is this a once-in-a-lifetime risk for public health? And we're going to have mass gatherings across the whole United States, not just here in Kentucky. This is the one time this eclipse goes clear across the whole United States in like 175 years or 385 or something like that. We're going to have, as Jim was noting, lack of adequate food and sanitation facilities in the areas where people are going to. Of course, they're flocking to the rural areas because that's where they can see the event the best. We're going to have people looking at the sun, something you've been told since a child not to do. We're going to have city dwellers camping. So what could go wrong? So there's some risks that we might expect. Of course, heat stroke and dehydration, Jim talked about those. GI illnesses, because we're going to have a lot of food vendors popping up. Respiratory illnesses, especially acute, like asthma, if people get into some situation where there's some kind of pathogen around and they are not pathogen but contaminant and they get asthma, or infectious, which we probably wouldn't see on site unless people have been there long enough. We'll see that popping up afterwards. Injuries, of course, people are going to be out in the fields. There's going to be possible car accidents, things like that. Eye injuries, as Jim noted, those will come later on. They won't necessarily happen right then unless somebody just really stares at the sun. Alcohol-related issues, injuries related to that, or car accidents may be a big issue. And then sewage and sanitation exposures, because there's going to be a lot of human waste and not a lot of places to put it. So there's going to be some issues with that, I expect. So there are some risks we might not expect. So as many of you are familiar with dog bite and skunk bite and raccoon bite situations with rabies exposures, there could be a lot of animal bite exposures. Okay, you're putting a whole bunch of people out in fields in the middle of rural Kentucky, fields that normally have animal populations, and where are those animals going to go? Well, they're probably going to be rooting around for food and mixing in with the people and everything else. So skunks, bats could be flying around, raccoons, things like that. And what about vector illnesses? So I was just in Western Kentucky for the eclipse exercise, one of the things Jim talked about, and my wife and I made a little extra vacation and spent a couple days, and we went hiking at Ken Lake State Park, I believe. We came back with ticks all over us, and we weren't even in high grass or anything. So, and we had spiders all across the walkway that we were knocking out of the way, and mosquitoes, of course. So of course, the people that are out there right now are going to be exposed to all those same things. So there could be dermatitis and rash illnesses as well, poison oak or ivy, things like that. One thing that came up at the exercise was, what about drug overdoses? So there's going to be a whole bunch of people here to see the eclipse. They're going to be partying. Who knows how many drugs are going to be there? Who knows what's going to happen? So we could have rashes if there's somebody who brings in some heroin and it's laced with fentanyl or carfentanil. We could have a bunch of drug overdoses and drug overdose deaths possibly. I was on a call yesterday or the day before nationally about the eclipse, and the guy in Oregon that was talking said, oh, you got road rage on your list because we think there's going to be tons of people who are going to be really angry because they're going to be rushing at the last minute to get there. The roads are going to be jammed, and there are going to be people really upset and shooting to each other and stuff. So he said road rage is definitely something to think about, but also violent behavior. We've seen that across our nation the last couple of days, and you're going to be throwing a bunch of people together who may have very different political views, so we may have some issues with that. Accidental drownings. You know, in Western Kentucky, where are some of the people going to be viewing this? Out on boats, because they got a lot of lakes, you know, and so we may have boat accidents and people drowning, things like that. And this is all going to be compounded by, as Jim was noting, impassable roads when there's too much traffic out there, a lack of adequate emergency medical service resources. Are there enough hospital beds if we do have a mass casualty event, and do we have the capacity to move people quickly to where they need to go? So what should we expect? So there's all these things that we can worry about. What should we expect? Well, it's probably not a doomsday scenario. You're going to have some stupid people doing stupid things, but all in all, they'll probably just be viewing the eclipse and going home in the next few days. So let's look at some past experiences that we've got. We have two that I wanted to highlight. The World Equestrian Games, which was in 2010 here in Kentucky, just outside of Lexington at the Kentucky Horse Park. There were 632 athletes, 752 horses, 420,000 visitors over 2 weeks, and 58 countries were represented. We're having the same thing with the eclipse. People come from other countries. It generated about $11.3 billion in revenue. Let's hope the eclipse does as well. when I was down at that Eclipse exercise, we were eating in a restaurant, I'll just tell you on the side, and some of the local folks started talking to us, and one of the guys says, well, I just rented my room out for $2,000 to somebody from Norway who's going to come for a week. So, I mean, so we got people coming from all over paying a lot of money to the local economy. And then also the NASCAR Sprint Cup race, which started about 2009 or 10, and we have that every year up in northern Kentucky. So we've got a little experience with that. That's an annual race, and they have about 100,000 people that come in for a week in a very concentrated, small area. So just to look quickly, and I don't know if you can see this very well on the screen, but this is a graphic of the things that we saw at the World Equestrian Games in 2010. So you see on the right-hand side it says dermatitis, GI, injury, neurologic, and respiratory. So you see that injury, the orange one, shows up quite frequently, as well as respiratory. But interestingly enough, neurologic, actually, the blue one, shows up quite a bit in there. So there's people that have dizziness or passing out or other neurologic symptoms. So we would expect the same kind of thing at this Eclipse event, where people are overheated and things like that, and maybe on drugs or whatever else. So we can expect all kinds of things. Dermatitis, of course, that's not out in a rural area. That's in the Kentucky Horse Park. Didn't see a lot of that. GI, we did have an outbreak right at the very beginning of the Kentucky or the World Equestrian Games. It was minor. We couldn't figure out where it came from. It was a food vendor, but that couldn't prove anything. But other than that, we didn't have any huge outbreaks. And we've seen that with a lot of mass gathering events, that we don't get a lot of the stuff you would expect to have a lot of bad stuff happen, because people are generally taking care of themselves. They've got their own food sources because they brought it with them and things like that. So sometimes there's a less likelihood of some of those kind of things. The Sprint Cup NASCAR event, this may be more similar to what we're going to see for the Eclipse, because you've got a whole bunch of people. Roads get jammed. They come to a very small area. There's food vendors that pop up all over that want to sell their goods. There's heat and humidity issues. That's in the first week of July, usually, or second week of July, so it's very hot. And sanitation issues, because they don't have camping areas for everybody, so people kind of go everywhere. Literally. So Sprint Cup outcomes. The primary activities that they were doing were the food vendor inspections, sanitation issues, and then the epidemiologic surveillance to see what's going on. And the outcomes that we saw, there's often injuries related to alcohol consumption. That's pretty common there, people tripping downstairs and hurting themselves and things like that. Other alcohol-related issues, just being drunk and doing dumb things. Heat stroke and dehydration. The really important point, I talked to Justin Pittman about this, is that, their activities don't end when the Sprint Cup is over. They go on about a week longer, because there's surveillance for other outbreaks and things like that might have started at the Sprint Cup, but then they continue on. And I think we'll see the same thing with the Eclipse. If there's bad food vendors, you're not going to necessarily see it right on the spot, but you'll have people reporting, I got really sick, and so then we might have to go back and look at that. So what are we doing to be prepared? Jim talked a lot about this, but there's several things I want to bring up. Syndromic surveillance is one thing that I'm going to talk about. Our Epi Strike team, the Operations Centers and Coordination, which Jim covered really well. Business as usual. Our regional EPIs, nurses, and environmentalists are still going to be out doing their jobs, and that's what really gets us prepared to report, investigate, educate, and intervene in whatever's going on. And then our mortality data management system I want to bring up real quickly. So, enhanced syndromic surveillance. So what is it? So syndromic surveillance, just to give you a brief overview, is really looking at syndromes. You may not know what illness people are getting, but you may see an increase in GI illness. Now this can be detected in a number of ways, like if you're looking at drugstores, is the Pepto-Bismol flying off the shelves? Or are the local emergency departments seeing a lot of people with severe diarrhea, or local doctor's offices? So there's different ways to look at this. So what we're doing in this situation is proactively tagging emergency department visits associated with the Eclipse. So why should we do that? And I'll talk about that and what that tagging means in a minute. Why do it? Well, this can help us to detect epidemiologic links in the outbreak setting. So if we say we've seen 5 people with a GI illness and they're all here for the Eclipse event, we might find out, wow, they all are staying at the same campsite, or they all ate at the same food vendor, things like that. So we can maybe establish those links a little quicker because we're picking those cases up sooner. It informs our public health response. So if we do get useful information, then we can do something about it. Go inspect the food vendor or the restaurant. And it helps to quantify the public health impact of an event for future planning purposes. So it kind of helps us to see, how did this event go? If we have something similar in the future, not an Eclipse, but some other big event, then are we ready for it? And what do we do to get ready for it? So here's some examples real quick. And I just want to give Kristen Heitzinger credit for these. She produced these slides for another talk, so I yanked them from her. So there was during and the post-Hurricane Irene in 2011, they did some genomic surveillance, a fake St. Patrick's Day in Kansas, a 2014 Super Bowl in New Jersey, and the 2015 Special Olympics World Games in Los Angeles. So they've used syndromic surveillance in all these settings to try and pick up things that are going on during the events. So how do we do it? So there's 5 hospitals in or near the eclipse path that'll be monitored, and this is monitored via the Kentucky Health Information Exchange. So that feed is coming in from those hospitals, and we're pulling data out of that to look at to see what's going on. Those hospitals are Jenny Stewart, Muhlenberg Community Hospital, that's Owensboro Health, Trigg County, Livingston, and Baptist Health Madisonville. So those 5 are all feeding data into this system to look at the eclipse event as it goes on. So when we say they're going to tag emergency department records of known eclipse-related events, the staff is going to enter the word eclipse in a certain field, in their chief complaint field, when they put data into their system. So that word eclipse is going to be in there, and we can search on that and say, pull all the eclipse visits out. Anybody there for the eclipse. It's not just a normal, I live in the community, I've got asthma today. It's I'm here for the eclipse, I'm staying at this campsite, and I got really sick or got injured or whatever else. So the way that we set it up is the emergency department IT staff have provided the Department of Public Health with a screenshot of where eclipse can be entered in their particular hospital's patient registration system. And then the IT staff have sent tagged test records to us so we can see does this work or not, and then they received confirmation from us that we receive the message, we see that we can get it and identify it. So there's going to be surveillance in advance of the eclipse from the 2nd to the 11th, so that's already going on, or already went on. It should say 17th, I think. They're going to adjust the tagging as necessary, so if it's not working quite right, they worked on it to see if they could get it set up so it's working, and then got instructions out to the registration staff. They use screenshots and visual aids to remind people to do that during the eclipse. And then during the eclipse, this is still pre, but 17th to the 22nd, they're going to do that. They're going to tag those records, we're going to pull them and look at them and see what's going on. And so we have people locally at the Orcharddale Farm and then also here that'll be looking at that data, and then we set up data dashboards for the participating emergency departments. They can pull up this dashboard online and look at it and see what's going on in their local area, see what's popping up. So after the eclipse, we hope to do a presentation at the next Healthcare Preparedness Coalition Region 2 meeting and provide emergency department specific surveillance reports if they want that, so just to see what came up out of it. So this will be a really great situation to test out and see how this works and to maybe give us some good information during the eclipse. So moving on to the EPI Strike Team, I'm going to move fast here because we're a little behind schedule. We have 6 members identified for our EPI Strike Team. They are not going to be deployed right now. They're pre-identified and they're ready to deploy. One of them is on site and there's some others up here in Frankfurt. And so they'll be ready to supplement local health department staff if there is a problem, or they can operate independently as a team and go out and investigate something that's going on if we have to do that. So that stands at the ready. The Operations Center Jim talked about, State Health Operations Center, State Emergency Operations Center, Regional Response Coordination Center, and we have public health staffing in all 3 locations and can stand up our shock in a moment's notice here because I'll be here, a bunch of other people will be here waiting for that if we have a reason to. So let's get to business as usual, and this is the real EPI Rapid Response Team part of the talk. So the best preparation we have for an event like this is our daily operations. It's having our EPI Rapid Response Team available when something happens. We do rapid investigation of reports that are out there, which our public health nurses and our epidemiologists do all the time. Get that information submitted quickly. Now, in this case, we're going to be submitting it to the Regional Emergency Coordination Center or the State Emergency Operations Center, or the SHOC if that's stood up, the Health Operations Center. But we'll be trying to get that information as soon as possible. But it's still the same process we always follow. Is if you see an outbreak, you see something going on at the local area, you report it up to the state so that we can give an outbreak number and then start helping with the investigation. So the big deal here is going to be coordination of resources and personnel as needed, because we may have a big issue in one area and nowhere else, so we may need to shift some people there to help out. So we may need additional resources like the EPI Strike Team or other epidemiologists or nurses or environmentalists to go work in a certain area. And we've done that in the past with the Sprint Cup NASCAR thing. We've pulled environmentalists from other counties to go up there and help with the environmental inspections and things like that. So we're prepared to do that. So what is business as usual? Now we're going to get in the question and answer period, and I know you can't really answer from afar very easily, so I'm just going to give you a chance to think. So what's the first step in an outbreak investigation? Da, 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 da. So I know you've all been to ERRT training or you wouldn't be here, right? So I know you know the answer to this. The first step in the outbreak investigation is prepare for field work. So my question is, are you prepared? Okay, so what do we do to prepare for field work? Do you have your resources available? The Control of Communicable Diseases Manual, the Red Book, all those kind of resources. Are you ready to go on the road? You know, if something happens, do you have yourself ready that you can hop in your car and take off and go investigate if there's something happening? And who's going to go with you? If you talk to your health department about who the staff is it, you know, do you have environmental staff identified? Do you have clinical staff identified? Do you have epidemiologic staff identified? Preparedness folks? All those people can share a role in this and be part of what's going on. And actually, it works great if you all work together. So, does your leadership have a plan and a schedule for who's working where and when during the Eclipse event? So, outbreak is reported. So we've heard, oh gosh, there's an outbreak at Orchard Dale Farm and all the public health preparedness staff are sick. What do you do first? What's the first thing you do? Okay, so we've done our first step in the 10 steps of outbreak investigation. We're prepared for field work. What's the next step? Well, it's confirm the outbreak. You got to know, is there really an outbreak? And I'm going to say, or an event of public health significance or importance in this case, because we might not have disease outbreaks. You may have a whole rash of illness, injuries or drug overdoses or car crashes. There may be some other thing that's important, but it's not necessarily an outbreak per se. So how do you do that? How do you know if there's an outbreak or not? Well, is what you're seeing more than would be expected? I know this is refreshing people's memory from the ERT training. The problem with that is, what is the baseline? We don't usually have an eclipse in Kentucky. So the last eclipse like this, full eclipse of the United States, was in the Pacific Northwest when I was in high school. So that was many, many years ago, and I actually got to see that. And I didn't go blind. But it doesn't happen very often. So what is the baseline for an event like this? Well, you know that there are things that are going to happen, those respiratory illnesses and GI illnesses and heat and dehydration, those kind of things. So are we seeing something that's really going beyond? There's going to be normal occurrences of that kind of stuff, but are we seeing something that may be due to something, not just because of people not hydrating themselves and things like that? So it's likely to be a judgment call. Use common sense. You know, think about it. Think about what's going on. Don't minimize what's going on, but don't maximize it either. Don't say, oh my gosh, the sky is falling, literally the eclipse happened, and we got to go out and do something about it. So next step is to verify the diagnosis. So what is going on? And I'm not saying infectious disease illness necessarily. What's the situation? It might be obvious. You might have a rash of drug overdoses, so it's obvious there's something wrong. People are doing drugs, first of all, and second of all, they might be using tainted drugs. So they're not taking what they think they're taking. There may be an epidemic of heat stroke because people are dropping like flies because it's super hot out there. I just looked at the weather before I got on, and it's actually looking better now for out there. Yesterday it said there was a chance of thunderstorms on Monday. Now it looks like it's going to be partly cloudy on Monday, and the thunderstorms have moved to Tuesday. So maybe it's getting better for that area, although then that increases the risk of heat stroke and things like that. So it might be your best guess. If it's a GI illness, you know, if people are getting sick within 24 hours from eating something, they all get, a bunch of them get sick at once, and they're all throwing up, and then they're good after another 24 hours, it's probably norovirus. You don't need a lab test to figure that out, but you might have to make a good guess and then find out where the source is. Neurological syndrome, you know, that may be something you've got to really think about. You won't have definitive lab results on the spot because that takes some time. So gather as much information as you can, that's the key, and look at it from all perspectives, clinical, environmental, epidemiologic, to try and come up with some ideas about what might be going on. Can you quickly identify the source? This is probably the most important part of it. Because if you can, you might be able to implement control measures. You want to work to prevent further cases by removing your exposures or educating people about the risks and prevention strategies, and you might disseminate information to other venues where it's not happening, in case it might happen there too. If you think there's a probability the same thing happened in other places, let people know. So if you can't control, prevent, or identify a source, you need to get together and determine what information you need to gather in order to figure that out or figure out what's going on. So you might want to meet with your clinical staff or people from other areas, whatever you need. Get together, brainstorm, say, okay, here's more information we need, let's go talk to the folks. And take the proper precautions to avoid becoming part of the outbreak yourself. So you know, an example I have is when I was in the Indian Health Service many years ago, we had an outbreak of hepatitis A in an Indian reservation in a very rural area. They had a grocery store far away. The only food you could really get in the community I was in was, there was a guy selling burritos out of his trunk in the parking lot of the health department. Well, during a hepatitis A outbreak, that was not where I went for my food source. Okay, so think about those kind of things. Don't expose yourself to what could possibly be a source of the outbreak. Okay, so remember your resources: the Control of Communicable Diseases Manual, CCDM, the Red Book, the Kentucky Foodborne and Waterborne Disease Investigation Manual, Reportable Disease Desk Reference, Google. I took this slide directly from my ERRT training. Be careful, you know, stick to reliable sources like CDC and NIH and peer-reviewed literature, because you can't believe everything you read. Define, identify, and count cases. So once you got something going on, you need to find out how many people are out there. You need a case definition with person, place, and time, and your clinical lab characteristics. You need to look for more cases as appropriate, create a line list, all these things you guys should know from Epi Rapid Response Team training. Eyeball the data. Look at it. You know, does something stand out? Did everybody eat at an ice cream parlor in Grand Rivers? You know, not Patty's, because that would never have a problem. But you know, is there a problem with some particular food vendor? So create a crude epi curve if that would be useful. You may not have time to do that, but it may help. And make your best guess. What's leading the outbreak or the public health outcome? It may be obvious, may not be. If it appears to be expanding, pull in more people. You know, if you need help, ask for it. There's the regional and local epidemiologists. You can consult the state. We might have to activate the SHOC here in the state because we may need to coordinate more. And you might need to request the Epi Strike Team. Does your theory hold up against the facts? If you have an idea what's going on, like everybody ate at this one ice cream vendor, did everybody really eat there? Ask those questions and find out, you know, because maybe only 50% of the people did who were sick, and they all got sick on the same day, so that's obviously not the source then. If so, take action, and we will be here to help. So last slide, mortality data management system. We are standing by in case there's a number of deaths. If something happens related to the eclipse attendance, we want to track those deaths. Now, we don't have an event created yet, but that can be created in 10 seconds. So if there is a rash of deaths for some reason, we need to know that. Our regional epidemiologists and coroners and medical examiners can enter that data into our mortality data management system so that we can have accurate counts here at the state. The governor is always asking for those kind of things if something happens, so we need to have that information. So if that does happen, report any deaths that occur in eclipse event attendees and assist in determining whether the death is related to eclipse activities. I mean, somebody could just have a heart attack because it was their time to have a heart attack, but they could have had a heart attack because they were completely dehydrated and they're out in a campground and they weren't taking care of themselves because they were at the eclipse event. So, or drugs laced with carfentanil, you know, shared at an eclipse event, things like that. Okay, I want to acknowledge Kristen Heitzinger and Justin Pittman, who I already talked about. Amy Colwaite was the officer during the World Equestrian Games, and I gathered information from her for that. And there's my point of contact. And thanks. I got us almost back on schedule.
Thank you, Doug.
You're welcome.
Casey, are there any questions or Tony, are there any questions for Dr. Thurman? Okay.
Nope.
As always, you're a wealth of information, Doug.
Thank you, Joy.
And Doug, last night, you all sent me his presentation at 11:30 last night. So, and I was up. I don't know which is worse. That you sent it to me at 11:30. I was awake to get it. So, thank you so much. Appreciate it for everything that you have done. Next, we have Christy Royalty, who is the nurse consultant in the Division of Epidemiology and Health Planning with the Immunization Program, and she's going to talk to us today about measles. So, Christy, how are you? You brought your red book with you?
Yeah, speaking of the red book, there you go.
Yeah.
Hi, good morning. Thank you, Joy, for allowing us to come talk. First and foremost, there are no measles cases in Kentucky. This is just yes. And when Doug and when they talk about outbreaks, let's not put that and measles in the same sentence anywhere ever together. But we're going to talk about what to look for and how to prevent in just a few seconds. And how about arrows? Is that right? Yep. All right, great. Great. All right, I know everybody's heard of measles. We're just doing a little update here and a reminder what we can do to prevent, and in case we see it, what we do, and how everybody works together. Measles is a serious respiratory disease caused by a virus. Usually we'll see the patient start out with a fever, cough, runny nose, and red eyes. And after about 2 to 3 days, they'll have what's called Koplik spots in the mouth. They're bluish in color, and you might see a fever spike to 104 degrees or more. After this, you have all this before in a more prodromal state, and then you'll see the rash start. It starts along the hairline and progresses downward to the chest, out to the back, and then to the legs. The rash is maculopapular in nature, and it goes away the same way it appeared. Measles is highly contagious and spreads through the air when someone coughs or sneezes. It is so contagious that 9 out of 10, oh, I'm sorry, thanks, Julie. It is so contagious that 9 out of 10 people in an area together might get it if they're not protected. You can get measles just by being in the same room where a person with measles has been, and the virus can stay in the air for 2 hours after the person has left. The rash usually appears 14 days after exposure. So we're talking about the amount of people that are going to be at the eclipse in small spaces, if there's an international traveler who's not been immunized, because Europe is seeing a lot of measles cases right now. So if we're seeing those come over and they're in a small space together to try to see the eclipse, the spread of measles would not be hard to do. All right, the infectiousness of measles from 4 days before rash onset to 4 days after the rash onset. Incubation period is about 8 to 12 days after exposure, and like I said before, the rash is typically 14 days after exposure. So what do you do if you have somebody that calls? Hopefully they call you before they come into your clinic and say they have a rash illness, or they have somebody that has a rash illness. You want to promptly isolate the suspected patient to avoid virus transmission. If you do get that call or somebody comes in and you see they have a rash, try to bring them in a back door and then have them exit out the back door. Do not let them sit in the waiting room until you're trying to figure out what's going on here. Report to your local health department while the patient is in the office, clinic, or the emergency room. Of course, if it's after hours, call 1-888-9-REPORT. Contact our immunization program to receive authorization to submit a specimen to DLS. And once we okay that, the specimen comes to DLS, and then they send it to New York for their final confirmation, if that's what it is. We want to obtain the appropriate specimens for testing, a throat swab or nasopharyngeal swab and viral transport medium for PCR testing. If you can, have someone take a picture of the rash and send it to us. That is so important. There are a lot of providers out there that may not have seen measles because really it's been eradicated from the U.S. since 2000. So a lot of your newer providers may not have actually seen the rash except in pictures. But we do have physicians that we work with here in KDPH that have seen it. And so if you can send those, we can share those, and that helps us to know maybe before we get that lab test back if this is what we're looking at. All right, investigation of suspected cases. Always want to obtain a copy of the medical record of the suspected patient, obtain the vaccine history, see if they've had their MMRs, and begin a contact investigation. All persons who may have had contact with the suspected patient in 4 days before the rash onset, assess for presumptive evidence of measles immunity, and check for your MMR doses in the Kentucky Immunization Registry. Your contact investigation is extremely important if you're going to be able to give MMR for PEP, which we'll talk about that in just a few minutes, because you only have 72 hours to get that MMR to those people that are not previously immunized. We also recommend immune globulin within 6 days of exposure for those babies less than 12 months who've not been immunized, pregnant women with no evidence of immunity, and severely immunocompromised persons. So presumptive evidence of immunity for community contacts, not healthcare workers. We'll talk about that in just a few minutes. The acceptable presumptive evidence for measles immunity includes at least one of the following. Under the first bullet, that would be your immunization, your MMR at 1 year, and then for your preschool kiddos and your babies, and then the second dose at 4 to 6 year olds or for adults who've not previously been immunized. Laboratory evidence of immunity, which usually looks like an IgG on a lab form. Birth before 1957, laboratory confirmation of the disease, which confirmation is from a PCR that we talked about appropriate testing before. Persons who do not meet this criteria are considered susceptible and should be vaccinated unless contraindicated. All right, PEP, post-exposure prophylaxis, what I touched on just a few slides ago. So we use MMR and immune globulin to prevent measles in exposed persons. So presumptive evidence of measles immunity should be assessed for all identified contacts. We give the MMR vaccine within 72 hours of initial measles exposure for those that are vaccine eligible and who have not been vaccinated or have only had 1 dose. The immune globulin can be administered either intramuscularly or intravenously within 6 days of exposure. And again, that's for infants younger than 12 months, pregnant women without evidence of measles immunity, and those that are severely immunocompromised. Individuals who receive the MMR vaccine or the IG as PEP should be monitored for signs and symptoms consistent with measles for at least one incubation period after they receive it. So measles in healthcare settings. Persons who work in healthcare facilities are at increased risk of exposure to measles and risk of transmissions to persons that are already at high risk of severe measles. All persons who work in such facilities in any capacity should have presumptive evidence of immunity to measles to prevent any potential outbreak. So this is a little bit different than those just community contacts. So the presumptive evidence we want to look for in healthcare workers. We recommend all persons who work in healthcare facilities should have presumptive evidence of immunity to measles. This information should be documented and readily available. Presumptive evidence for healthcare workers is written documentation of 2 doses of live measles or MMR administered at least 28 days apart. Laboratory evidence of immunity, which again looks like an IgG on a lab form. Laboratory confirmation and birth before 1957. DPH does not recommend that this criteria be used as presumptive evidence of measles immunity for healthcare personnel. So if the person is unsure, if you don't have documentation that they've been immunized or that they've had the disease, if they're unsure, always immunize. So just a little history on what's going on, none in our state, but around the nation and internationally, just over the last few years, where measles cases have been and where outbreaks have been. Just this year, from January 1 to July 15th, 117 people from 13 states were reported to have measles. Minnesota is having the greatest by far. It's having the largest outbreak of measles in 30 years. As of July 13th, they've had 79 confirmed cases. 71 of these cases have not been vaccinated. 81% of the total case count are Somali Minnesotan. So this current epidemic may be due to travel between the Somali Minnesotans and their home country. Last year in 2016, 70 people from 16 states were reported to have measles. In 2015, 188 people from 24 states and D.C. area. The United States experienced a large multi-state measles outbreak linked to an amusement park in California. The outbreak likely started from a traveler who became infected overseas with measles, then visited the amusement park while infectious. However, no source was identified. And then in 2014, the U.S. saw its largest number of cases of measles to date, with 667 in 27 states. This is the greatest number since the elimination of measles was documented in the U.S. in 2000. The majority of people with measles in individual cases or outbreaks are unvaccinated. Like I said before, measles is still common overseas in Europe, Asia, the Pacific, and Africa. Travelers with measles continue to bring the disease into the U.S. So again, let's hope we don't see that this weekend with the eclipse. Measles can be spread when it reaches a community in the U.S. where groups of people are unvaccinated. All 50 states have medical exemptions from vaccines. All but 3 states here in the U.S. allow people to refuse vaccinations for religious reasons, and those states are California, Mississippi, and West Virginia. Kentucky still allows people to refuse for religious reasons. And just with our new legislation, a medical provider does not have to sign on their certificate anymore. It can just be by the parent, but it has to be notarized. 16 states allow people to refuse them for philosophical or personal reasons, and thank goodness Kentucky is not one of those. So MMR immunization for international travelers, sometimes we get those calls. And you at the local level may get those calls as well from your community members that are going to do mission trips or just going to travel overseas about what they need to do in regards to MMR. So before any international travel, we recommend infants 6 months through 11 months should receive 1 dose of MMR vaccine. Children 12 months and older should receive 2 doses separated by 28 days. And then teenagers and adults with no evidence of immunity should also get 2 doses of MMR separated by 28 days. For your infants less than a year, so less than that 12-month-old when they would normally be recommended to get MMR, they should get 2 more doses one dose at 12 through 15 months of age, and then another dose at least 28 days later. And these are just resources that I use to gather this information. Our pink book, the red book, the CCDM, the CDC is a wealth of knowledge. And then Minnesota, they've done great work with this measles outbreak that they've had. So any information, or if you're just curious, let's hope we don't have to use it. But they have done great work and have a lot of resources on their website as well. And then just contact me, Julie, anybody in the immunization program with any questions, Dr. Brawley, and then again the after hours number is 1-888-9-REPORT. Thank you so much.
Thank you, Christy. Are there any questions from the field for Christy? Casey? No? Okay. Thank you, Christy, for your measles update. Appreciate it. Next, I'll ask Julie Miracle to come to the front of the room to provide her presentation. Julie is a nurse consultant also with the immunization program within the Division of Epidemiology and Health Planning. And Julie's here today to talk to us about the new immunization regulations. And so there were, I believe, some questions and from the field. And so Julie would like to take this opportunity to clarify some of the confusion and answer any questions that you all may have. So thank you, Julie, for taking time out of your day to come and talk about the new regulations for immunizations.
Thank you, Joy. Sure. I don't have a presentation. I am just going to go over some of the highlights from the regulation. I sent out about 4 weeks ago update, I guess it was the end of July, the updates and bullets to the regulations to all the nurses. So hopefully that you've got that. The regulation passed on June 21st. It took 3 years for us to get this regulation out. A lot of blood, sweat, and tears went into this. I probably sold my oldest child to get this passed. So hopefully, you know, if you have any questions, please call us and we'll work through this. But I'm going to go over some of the real highlights that we have been getting questions on. And one of them, the first one I'm going to go into is the immunization requirements. We did this to strengthen our immunization and the coverage rates for all children. And the first one is the hepatitis A. This is a 2-dose series that is required for all children ages to start at age 12 months, that you give 1 dose and then complete it at 18 months of age. And then if they are not caught up and have not received a 2-dose series, that they are going to complete it by get it completed, and they have that in all the way up to 18 years of age. So we want to have that hepatitis series on that. The immunization requirement will go into effect on July 1st of 2018. We wanted to give you a year to get caught up, but remember that the hepatitis series is 6 months minimal interval between the 2 doses. So we would like you to start immunizing those kids that are not caught up. So if they don't have that hepatitis series on their immunization records, you need to get them caught up. So nobody is grandfathered in. So we want to make sure that everybody is aware of that we get these children back in. The quadrivalent meningococcal vaccine is now abbreviated Meninge ACWMY. That is a booster dose for all children 16 years and older. So we will be looking next year at the 11th graders and 16 years and 17 year olds and 18-year-olds will have to have that certificate. All homeschool children will now be required to submit an immunization certificate for both public and private school, whatever they do related to public and private school. So if they're coming in for sports, enrichment activities, they will have to submit a certificate. All the vaccines are now listed on the immunization certificate that are recommended by the ACIP. So you will see HPV and rotavirus. They are not required for enrollment into schools, but we wanted to make sure that providers or that the schools were able to see that immunization. All right, so the next big bullet is the declination form, and so we are getting a lot of calls on the declination form. You do not need to go. The declination form was let's see, how do I put this? You will not need to go to a provider to get a declination form. The parent can go online to either the Kentucky Department of Education or to the Kentucky Immunization Program website and print off a declination form. They then need to take it to a notary and get it signed and fill it out. And that, if they don't want any immunizations whatsoever, they take that just to the school. Now, if the child has an immunization history or they are only declining, say, varicella or MMR, then they will take that declination form to their provider, and you print out the immunizations history, and you take the immunization history. The parent will take the immunization history and the declination form to that. At this time, we're under the impression, and we are asking DPH legal counsel, we are under the impression that all children will need a new certificate next year because we've added a hepatitis A and meninge to our new certificates. That also includes that new declination forms will needed because of the notary signature. So that is, we are asking legal on that because if we're requiring it for one, we should be requiring it for the other group. And that, as far as we understand from the law, is that they do not expire unless the law changes or the parent decides to change their mind.
And
So
you'll keep us
yes, and so as soon as we get word back from Laura and the legal counsel, I will send out an email about that. But at this point, you know, if it does not list hepatitis A on the certificate or meningococcal or meninge ACYW, you will need a new certificate for the school year starting July 1, 2018. So not this year, but next year. All kids will need a new certificate. Okay, although the forms are available on our websites, on the immunization program website and also Kentucky Department of Education website. Now, medical providers, EMRs, and out-of-state immunization certificates can be accepted as long as they are meeting everything in the immunization certificate. So that has to include the child's birth date, the parent's name, address, the vaccines that were administered, including the hepatitis A and meningococcal now, a statement about when it expires, the expiration date, a signature, and where the vaccines were administered. With the new certificates, PCV, we listed PCV 13, and this was an error in our, in kind of when we were writing this. So make sure that the kids that were administered PCV 7, that you indicate the ones that were written PCV 7s, but make sure that the PCV 7s are on the pneumococcal line too. That's where you would put pneumococcal PCV 7s and 13s are on that one. we can't open the reg at this point to change the hard copy of the immunization certificate. If you print from the certificate or print from the registry, you do not need a signature because it is based on our regulation is based on our registry is based on the regulation. I'm saying that backwards, sorry about that. And so you do not need the signature. Ways to tell that it is from our registry: when it prints out, it will print out with a Kentucky seal on it, and then on the line where the signature is, there is a statement from the regulation saying that it is from the regulation. And then I think that was it on that. Okay. School nurses can join the Kentucky Immunization Registry and get access, and then once they get access, they can print from the certificates. I know that they will not be able, because of FERPA, will not be able to add any information, any immunization information at this point. We're working with the Department of Education and legal to try to figure out how we can get them to be able to educate and to enter that information into. It might be that they have to send a consent form home to every parent, but we are working on that one. And we learned that after 3 years of doing this. Routine reviews will occur with enrollment into daycares, kindergarten, 7th grade, 11th grade, and the 12th grade for the 2018 and 19 school years. And then reviews will continue this year just for kindergarten and 6th grade. And then all certificates will expire if they're not up to date. For daycares, they have 30 days to get them back into, to make them valid and get them back in. Parents do. And then for schools, 14 days so that they're up to date. LPNs can now sign the certificates. And that is it. Do you guys have any questions? I think those are the big questions, but I still want to emphasize the hepatitis A series. Now is the time to start looking at your certificates so that we get these children up to date. It's going to take 6 months. If they're not up to date, it's going to take 6 months to get them vaccinated, you know, and then any of the any of the juniors and seniors that haven't had that meningococcal ACY vaccination, we need to get them up to date too. But I've been looking at certificates because I'm in the registry every day doing validations and stuff, and I see a lot of the younger kids with, I mean, I see the hepatitis doses in there, so I'm not sure that we're going to need a lot of recall, but you know, just make sure if we just send out reminders to parents to make sure that they're looking for that hepatitis series. That's it for the regulations. Do you guys have any questions? Because I have some flu updates.
Hello?
Hello? I'm really surprised. And you can call me at the immunization program. It's 502-564-4478. I'm extension 4260, but any of the other nurses can answer questions, and Margaret can answer questions because she was on the committee longer than I was. But you can answer or email me at julie.miracleky.gov.
Is there a list of FAQs and answers?
Yes, and that is in its 3rd revision to Dr. Brawley, so hopefully I will get it out this week. But you know, we do have a lot of frequent questions, and like I said, the hepatitis A is the biggest one, and then the declination is the next one. That is, we're getting a lot of questions on just how to do it is basically, and we do have a instruction form that is, and that also had to go to legal to make sure that we were doing it correctly. So it takes a lot of process, and like I said, this was our third year that it went to legislation to get it through, and you know, it took all the way up to June 21st that we weren't sure if it was even going to get passed on June 21st, so we were holding our breath there. So you know, we celebrated that day. So, you know, at that time, then we were like, okay, now what do we do? So, you know, we were telling everybody that we were going for Hep A and meninge, but, you know, those were the, you know, so hopefully people have been vaccinating, and it looks like we have, but, you know, there's still probably people that, I think the older group, the high schoolers, were going to be the ones that we're going to have to go for. Okay, moving on to flu, since I didn't have any regs questions. The MMWR for the flu, which we base our protocols on, has not come out yet, but it doesn't sound like there's going to be much change from just the ACIP meeting. It's going to pretty much be basically vaccinate as usual, but I can't guarantee that until it comes out. I do know that with the vaccine has changed a little bit. The the influenza A H1N1 has changed. Why? I don't know, but I guess with just different matches with the circulating virus, they decided that it should change. And this is what they're using down in the southern hemisphere, and Australia has had the worst influenza season in the last 10 years. So look out. I'm afraid that we might have a big influenza season this year. All right, flu, and I just lost the name now. GSK has a new universal flu vaccine. It's 0.5 mils, and it's for 6 months and above. It will be given to all people. So be careful when you're using that. Make sure that you're all looking at the doses. So when those babies that need the 2 doses, I'm sure it's going to be under 8 for first time vaccinating, but you know, we'll have to wait for the MMWR to come out. But those 2, make sure that you're looking at your package inserts and looking at what you're giving. But this GSK vaccine has a universal dose. So be very careful with that, because those kids are going to still get 0.5 mils like an adult does, but they'll still need their 2 doses for that first vaccination season. And just because I'm one of the flu nerds, if you start seeing flu in your community, you know, hopefully that we will not be seeing it, but we have been seeing sporadic cases through the summer. If you start seeing it increase, you know, fever, sneezing, respiratory things, school closing, long-term care outbreaks, to let Troy Cunningham or myself know. And an outbreak of a long-term care is defined as 2 cases with signs and symptoms, including rapid testing. And that's it. And as soon as we get those MMWR comes out, we'll get those protocols. But we wrote the protocols last year or 2 years ago as to be pretty much that they would move on, that we wouldn't have to do much changing to it. But last year we had to take the live vaccine out, and so that's why it was held up. So.
Well, and if there are any changes to the protocols, the immunization program does a great job with revising those, having those go through the review process, the nursing office, and then we would have those added as emergency changes to the CCSG. So, but the immunization program does a great job of reviewing the MMWR guidelines and making any necessary changes. So, more to follow on that as that information becomes available.
Right.
Yeah.
Just you know, again, just really look at your package inserts so that we don't have a med error on your dosing. And that was when I heard this universal dose for everyone. And then if you have to switch from GSK to Sanofi, that you're, you know, that there will be an error.
Yeah.
So just be very careful. So.
Good words of wisdom, Julie. Thank you for your updates, and you'll send out the FAQs on the reg once those get approved. Okay, those will be helpful, I'm sure, for everyone to use as a reference. All right, next, Colleen, you gonna come up next? Okay, you can. Oh, okay. All right, we have two more updates. I'd like to end. We've got Colleen Toffness from the Kentucky Women's Cancer Screening Program, and Brooke Happ is going to join us. She is an epidemiologist with the Division of Epidemiology, and Health Planning, and she's going to be providing us a brief Zika update. So, Colleen, why don't you come on up, and she has a few things she'd like to share. And Colleen is our clinical coordinator for KWCSP. Thank you, Colleen.
Thank you. Hi, I'm Colleen Toffness, and I don't really have any program updates, but while I had the platform and I could have the ear of all the local health departments, I did have a few things that I wanted to just shout out to you. So I want to address the nurse leaders and the nurse case managers at the health departments and just say a big thank you for sending me the names and the email addresses of the nurse case managers. I'm trying to compile a list of all their names and addresses and put them in one group contact so that I can easily communicate when I have some information that I want to send to all of them or when I want to request information. So I don't have everybody's yet. I'm missing about 20 either local health departments or districts that have not yet sent me their nurse case manager names and emails. So just keep them coming, please. I'm also updating our resource list, and I want that to be a continuous, ongoing thing so that when I send out the updated resource list, still, just anytime that you come across a new resource that would be helpful to all the health departments, just send me their information and I'll send out a notice with that group contact. While I was at a training recently, one of the educators made a comment about shower cards, and if you're still using them, that you probably needed to toss them because they're outdated. Well, that led me to come back and look at our shower cards and read them. And honestly, our shower cards are not outdated, the ones that we have a hold of. They still give proper directions for doing a self-breast exam. So her concern was that the shower cards were directing people to palpate for lumps while they were standing in the shower. Ours don't do that, so just look at your shower cards. They're probably correct information. I can't imagine that wrong information is being printed now unless you have really old shower cards. So, oh, and one more thing. Our little purple book, the Quick Reference Guide, is being updated. So the process is not complete yet, but I just wanted you to be aware that some of the information in the current one is old and some of the phone numbers don't work. So we will fix that, but it's in the process right now.
And you might want to share for some of the new nurses what the purple book is.
Okay, it's a reference guide for providers, and it just gives some quick information on our program, the Women's Cancer Screening Program, and the breast and cervical cancer treatment program. And so mostly it was the Medicaid side that the phone numbers, I think, have to be corrected. But we're working on that, and we'll get it updated real soon. Thank you.
Thank you, Colleen. Next, I'll invite Brooke to come up. Thank you, Brooke. Half, as I mentioned, is epidemiologist with the Division of Epidemiology and Health Planning. She's going to provide us a brief update on Zika. We went for a while there and kind of had a lull, and so now there's some more latest information. So thank you for coming today and providing an update.
I'm happy to be here. Thanks for having me. So, like Joy said, I'm going to provide you with a very brief update, and then we'll have time for questions, or you can get my contact information from Joy and call me or send me an email. So far in 2017, we've had 2 Zika cases, which is down from this time last year. Last year, at the end of August, we had 26 cases, and by the end of the year, we had 33. So we're seeing a lot less Zika overall, but we're still doing testing. The state lab has performed IgM testing on 52 samples and PCR testing on 54 serum samples and 40 urine samples. As a reminder, the PCR testing is looking for Zika RNA, and that's most likely to be positive within 2 weeks of exposure or symptom onset, and the IgM test looks for antibodies and is more likely to be there's a longer period. You might detect those antibodies for 12 weeks or longer. Those tests do have to be confirmed then by testing at a CDC or a reference lab. We haven't had any positive PCR results during the summer months when we would have an environmental response. The downward trend that we're seeing in Kentucky is being seen by our neighbors in the continental U.S. as well as sort of the overall trend in the Americas more broadly, and the U.S. territories. In June, Miami was removed as a cautionary area. The Pan American Health Organization has some really neat epi curves on their website. They have one that has all of Central and South America and the Caribbean, and then they also have individual countries, and you can see that there is sort of a big trend overall of that last year we had a spike in cases that we're not seeing this year, but there are also some country-specific things that are going on. In response to the declining case counts, CDC has scaled back its Zika response from a level 1 to a level 2, which is going down. That doesn't mean that happened on August 3rd. That doesn't mean the threat of Zika has gone away or that people aren't still at risk for Zika, but it just means that the response can be managed by fewer people. And so even at a level 2 EOC activation, CDC will continue to have a response, but they'll transition to the activities and responsibilities happening sort of across the agencies rather than all together. So I think that's the main update that I had for you all. If you have any questions, I can take those. All right, well, thank you so much. And again, if you want to reach out, Joy has my contact information.
Thank you, Brooke. So we're going to wrap up here. I've got a few announcements I'd like to share with you all. I hope you've enjoyed today's webinar and learned something new about public health nursing and opportunities that may impact your clinical practice. I'd like to share with you, first of all, the list of new Nurse Executive Committee members for this fiscal year, for fiscal year 18. We've got a whole new group of members, and our first meeting is going to be held August 29th, and so I'm very excited to announce the new members. Jessica Likens, who is with Gateway, Bobby Gray, who's with the Department for Public Health, Gina Reed, who's with the Department for Public Health, Sandra White, who is with Marshall County, Kathy Gifford, who is with Graves County, Christy Bowman, who's with Todd County, Tara Hart, who's with Christian County, Kelly Allen, who's with Montgomery County, Jenny Pyle, who's with Breckenridge County, and Stephanie Bentley, who's with Pike County. So congratulations to those nurse leaders. If you know any of those nurses, you know them, feel free to reach out to them. They're representing you all on the committee, and certainly you can always contact me as well. We'll be working on August 29th on our first meeting on our charter and determining some goals and objectives that we'd like to work on this year. Certainly the first and foremost responsibility for the NEC is to review the core clinical services guide and the protocols that you all follow in providing your nursing care, nursing practice in the local health department. So that'll be first on our charter for our deliverables. Next, I wanted to let you all know that we're working on, in the nursing office, a survey monkey that will go out to evaluate and obtain your all's feedback and input on the July 1st CCSG. Want to find out from you all as the end users how the process worked as far as the determination of the changes of those protocols, how that information was disseminated, and then hopefully you've had an opportunity to get in there and apply some of those revisions in your day-to-day practice. And are those revisions reasonable, feasible expectations for you in your daily practice? So that survey, I hope, will go out within the next week to all the local health departments that we have, nurse leaders that we have on our listserv. So the bigger response that we have, the better, and I'll be sharing those results with the Nurse Executive Committee so we can incorporate and implement your comments to make the CCSG as user-friendly as possible. Let's see here. Oh, and then also I wanted to let you all know, thank you, Casey Courtney thanks you for all of the named updates and names that you all have sent to her for our nurse leader list that's posted with all 61 local health departments. It's posted on the local health operations website. So it was time for a good scrub down on that list, and there were several nurse leaders who had retired or transferred to other positions. So we'll get that updated and posted as soon as possible. Then I wanted to let you all know, and some of you all may have heard about the status of ECW, and so I just wanted to read this memo, and I'll send this out later today. But this email was sent out to local health department directors yesterday regarding eClinicalWorks, which was our electronic health record vendor. And Mark Station is emailed to local health department directors and to all of DPH. The Kentucky Department for Public Health has announced that the contract with eClinicalWorks ending September 15, 2017 will not be renewed. DPH staff will be working with the 15 local health department sites, both clinical and dental, on an exit strategy to assist in the transition from ECW back to CDP. In closing, Mark states, we remain committed, meaning DPH and local health departments remain committed to establishing an EHR in local health departments and DPH. We will immediately commission a team consisting of local health departments, the Department for Public Health, and OATS, which is the Office of Administration and Technology Services, staff to develop a scope of work to use in an RFP to secure a new EHR product. And so an RFP is a request for proposals for new vendors to apply for a new EHR product. So more to follow on that announcement. And I will share that information, send out that email this afternoon. Are there any questions or comments that you all may have for me? Casey shaking her head no. Just as a reminder, this webinar will be recorded, and I'll ask my trained colleagues from Education Workforce Development to pull out that 1-hour segment from the Kentucky Coalition Against Domestic Violence from Mary Savage. I'll pull that out so that can be a 1-hour standalone module. And then those should be available here within the next several days for staff who may be involved in back-to-school activities and the clinics and couldn't participate in today's webinar. And then especially for that 1-hour standalone for later viewing, okay? And then also to come will be the updates and revisions to the administrative reference regarding House Bill 309. And probably what I'll do is I'll probably use a lot of that information from Mary's PowerPoint presentation to update that and have her review that. There will also be information providing documentation guidance for where that should be, most likely in your progress notes and your SOAP notes, I would say. But I'll include that so you all will have that for documentation guidance. So if there's no other questions, or no questions, I guess I should say, we've still got 2 minutes. I didn't think there for a minute we were going to get it all in today in 3 hours, and then we always end up getting pretty close. So thank you again for everything that you all do. And I know it's an extremely busy time. The next public health nursing webinar will be held on October 19th. So it'll be fall when we get back together again. So we look forward to having you all. Oh, and I forgot one other thing. The APRN conference, I just want to remind everybody, it will be held October 25th and 26th at my old Kentucky home. Dr. Glenn Farr, will be providing the 5-hour pharmacology course on the second day on October 26th. So more information will be forthcoming. Yesterday I sent out the hotel reservation information for your APRNs. If you have a contracted APRN, if you can make sure that she receives that information, because I may not have her email in my database. So have a great day, and we'll see you in October. So have a great day, and we'll see you in October.